Good evening, everyone. I'm Dr. Fawzia Rashid, consultant endocrinologist in Dubai Hospital. On behalf of the Emirates Diabetic Endocrine Society, a very warm welcome to all the speakers and audience today. Today, at the Forum of Young Leaders, we are having a session about cardiometabolic endocrinology. We are having total of 2 talks today. In 4 talks, the three are revolving around the diabetes and the lipids, and one interesting case presentation by Dr. Faryal for the ICI-induced diabetes, summary of key trials by Dr. Ishma, and about the precision lipidology by Dr. Nadal Haris, followed by the symposium, Dr. Jalal Nafash. So our first speaker is Dr. Ishma. She will be presenting all the key trial summary so far in the diabetes. Just to make you aware that this event is CME accredited, once you have received an email in your registered email address about the evaluation form, after filling the form, you will be receiving the CME accreditation. Regarding the Dr. Ishmael Ijazi, she's a consultant in telemedicine in Dubai Hospital. She's member of Royal College of Physicians and fellow of Royal College of Physicians, Edinburgh. She has cleared her specialty certificate examination in endocrine and diabetes, along with a postgraduate diploma in diabetes. Dr. Ishma has also a very strong interest in the research, and she's a very well literate about the diabetes and having a very widespread practice about the diabetes patients. So Dr. Ishma, kindly start sharing your screen and start your lecture.
Thank you very much, Dr. Fawzia, for this illustrious introduction. I'll just be screen sharing now. Can you see my screen?
Yes, we can see your screen.
All right, okay. So I think I'm Dr. Ishma, consultant medical from Dubai Hospital, Dubai Health. And today we're discussing cardiovascular outcome trials in type 2 diabetic patients. So we know that 60% of our diabetic patients have CKD or heart failure, and out of the whole spectrum, 1/4 of our diabetic patients basically land up in heart failure. We know that the 2-year survival rate is poorer for patients with heart failure than those with other cardiovascular diseases. And as we go by, we know that heart failure is the most common cause of cardiovascular disease related hospitalizations in type 2 diabetic patients. And we also see that patients with type 2 diabetes develop heart failure earlier than those without diabetes. So, this means that we need to address drugs, those medications which will reduce cardiovascular outcomes in type 2 diabetic patients. So, if you look at the journey in type 2 diabetes, we know that initially we had glucophage, then we had sulfonylureas, followed by DPP4 inhibitors and TZDs, and then we have GLP-1 receptor agonists and SGLT2 inhibitors. So, if we look at the medications for type 2 diabetes, we know that 15 to 20 years back, we had the advent of DPP4 inhibitors, and these included sitagliptin, saxagliptin, alogliptin, and linagliptin. And we know that the cardiovascular outcome trials it basically demonstrated cardiovascular safety, that is, non inferiority to placebo in type 2 diabetes. But we know that all the cardiovascular outcome trials, they failed to show superior reduction in major cardiovascular events while they were safe for ischemic events. But there were some trials raised concerns regarding increased risks of hospitalizations for heart failure. So, if you look at the DPP4 inhibitors and the cardiovascular outcome trials, we know that there's a SAVOR-TIMI trial, the EXAMINE trial, the TCOS trial, and the CARMENILA trial. So if you look at here, the SAVOR-TIMI trial was on saxagliptin. It showed no increase or decrease in ischemic events, but reported a statistically significant increase in hospitalizations for heart failure. If you look at the EXAMINE trial, the alogliptin trial, which was an allogliptin, it demonstrated non-inferiority for cardiovascular deaths, non-fatal MI, and non-fatal strokes in patients with acute coronary syndrome, but with no significant increased risk of heart failure. Then we had the landmark TCOS trial on sitagliptin, and which confirmed cardiovascular safety with no increase in MACE or heart failure related hospitalizations. And again, we had trials on linagliptin, the Carolina trial, which had similar cardiovascular safety profiles, and the Carmelina trial, which demonstrated safety in patients who are high risk with renal impairment, also with high risk diabetic patients. So, if you pull up all these trials, we find that they were neutral results. These trials were designed to meet FDA's safety mandates. They provided neutrality for major adverse cardiac events, meaning they do not increase or decrease risk of MACE. And again, but on the other hand, the SAVOR TIMI trial indicated a potential increase in heart failure related hospitalizations with saxagliptin, which was not observed with the same consistency across other DPP4 inhibitors. And if you generally compare the efficacy, unlike GLP-1 receptor agonists and SGLT2 inhibitors, DPP4 did not reduce all-cause cardiovascular mortality in pooled analysis of the trials. So again, if you would conclude, DPP4 inhibitors are considered safe for treating type 2 diabetes from a cardiovascular standpoint, but they are not the preferred treatment for providing cardiovascular protection compared to the new class agents. So I think let's go back to our journey in diabetic treatment. We know that we had 15 to 20 years back, we had the onset of TZDs. Now, if you look at TZDs, we had the proactive trial, and this was the first major randomized control trial which was done on pioglitazone, and it found a reduction in the secondary composite endpoints of all-cause mortality, non-fatal MIs, and strokes in high-risk patients. This was followed by the IRIS trial, which again found that pioglitazone significantly reduces fatal and non-fatal MI and stroke in insulin-resistant patients. And then again, we had the record trial on rosiglitazone, and which basically suggested that there were increasing cardiovascular deaths as compared to alternatives, which led to temporary restrictions placed on rosiglitazone. So if you just summarize the key findings, we know that pioglitazone, it is recognized for a positive or a neutral effect on cardiovascular events, especially recurrent strokes, but with a known increased risk of heart failure, weight gain, and edema. Rosiglitazone, initially studies suggest increased cardiovascular harm, although further studies resulted in lifting the FDA restrictions, yet it is rarely used nowadays. And as a class effect, we know that both TZDs, pioglitazone and rosiglitazone, they're associated with an increased risk of heart failure, and they should be used in caution, especially in people with symptomatic heart failure. So again, as we said that in journey of diabetic treatment, now we have new kids on the block. So now we are talking about GLP-1 receptor agonists and the SGLT2 inhibitors. So, cardiovascular outcome trials in type 2 diabetic, mandated by regulatory agencies since 2008, have transformed care by demonstrating that newer agents, especially our SGLT2 inhibitors and GLP-1 agonists, they especially reduce major cardiovascular events. And these trials, they move beyond glycemic control to provide cardiovascular safety and benefits in those people who have established diabetes. So again, if you look at the GLP-1 receptor agonists, we know that basically how it helps to reduce glycemia and HbA1c. In a nutshell, we know that it basically it causes an insulin secretion, which is as an augmentation of hyperglycemia. It suppresses glucagon secretion at hyper or euglycemia levels. It causes deacceleration of gastric emptying, preventing large post-meal glycemic increments, and it causes a reduction in caloric intake and body weight. Again, we know that we have the shorter acting agents, and they have reduced effectiveness in overnight and fasting blood plasma glucose, but they have maintained their effect on gastric emptying. We have the longer acting agents, which have more profound effect on overnight and fasting plasma glucose and HbA1c levels. And again, we know that the effect on gastric emptying, there is tachyphylaxis on this, and all these agents are known to reduce HbA1c and they cause weight reduction. So, the mechanism of cardioprotective effect of the incretin-based therapy is independent of the effect on glycemia. So, mainly it is attributed to multiple non-glycemic actions on the cardiovascular system, and this includes changes in insulin resistance, weight loss, reduction in blood pressure, and improved lipid profile. And also, they cause a direct effect on the heart and they cause a direct effect on the vascular endothelium. And they have significant superiority in reducing 3 point composite MACE in adults with type 2 diabetes. So, in a nutshell, if you look at the cardiovascular outcome trials, we know that we have the LEADER trial, which demonstrated a 13% reduction in MACE, the SUSTAIN 6 trial, which was on semaglutide, which reports a 26% reduction in MACE. We have the HARMONY trial, which was an albiglutide, which shows a 22% reduction in MACE, a REVINE trial, which was on dalaglutide. Then we had the SELECT trial, which was on subcutaneous semaglutide, showed a 20% reduction in MACE among individuals with overweight or obesity and established cardiovascular diseases. We had the FLOW trial, and then we had EXCEL trial on exenatide, and the ELIXIR trial on lixisenatide. So I think before we start, we know that in 2016 and in 2019, we had trials which were done on semaglutide, and these trials were basically done on small patients, small group of patients, which were less than 3,000 participants, and the trials were done for less than 2 years. So if you look at back in 2016, we had the SUSTAIN 6 trial, which was done on subcutaneous semaglutide. And this trial compared subcutaneous semaglutide to placebo, and there was a 26% reduction in MACE, and it was found to be superior to placebo. This was followed by the Pioneer 6 trial, and the Pioneer 6 trial basically compared oral semaglutide to placebo, and this was done in 2019. And also in this trial, we found that there was a 21% reduction in MACE. But again, if you look at this trial, we found that because the confidence interval, the upper bounds of the confidence interval, it exceeded 1. So this meant that this trial was not statistically significant. Due to this, this actually led to designing of more trials on GLP-1 receptor agonists, in which, the number of participants which were recruited were much more as compared to these previous trials. And these trials were also conducted for a longer period of time. So this basically led to the SOUL study, which was on oral semaglutide. And in this study, patients, they were either randomized to oral semaglutide maximum dose 14 milligram on top of standard of care, or they were randomized to placebo. And here we had included a large number of participants. It were over 9,000 people were included in this trial. So if you look at the patient characteristics of this whole trial, we are finding that basically most of the patients were obese. They had a BMI greater than 30, and they had diabetes for over 15 years, and all patients had cardiovascular and renal diseases at baseline. And again, these patients were followed up for a period of at least 50 months, which is greater than 4 years. So if you look at these trials, you will find that once you have oral semaglutide patients who were randomized to oral semaglutide and placebo, the only thing was that there was a large dropout rate here, which was about 27 to 29%. But if you look at the results, you find that there was a 14% reduction in MACE. And here the upper bound of the confidence interval was less than 1, meaning that this was statistically significant. So if you look at the secondary outcomes with oral semaglutide in the SOUL trial, we find that there was a 9% reduction in the hazards ratio for major kidney disease events, but again, this was not statistically significant. And we also found that there was a 29% hazard reduction in major adverse limb events, but this was also not statistically significant. Again, we have other trials on tirzepatide and cardiovascular protection. So this is one of the landmark trials which was done. This was SURPASS cardiovascular outcome study trial. And in this trial, we had compared two active agents. Yani we had compared dulaglutide with tirzepatide. So again, here patients were randomized to dulaglutide 1.5 milligram q weekly, and they were also randomized to escalating doses of tirzepatide, yani starting from 2.5 milligrams weekly, and they were escalated to 5 milligrams, 7.5, and then subsequently to 15 milligrams. And these patients were followed up for a period of 4 years. So here we see that, because now we are comparing two active agents, so it is very important that we need novel statistical analysis if we want to compare tirzepatide to a placebo, because in this trial, placebo is not included. So again, if you see this, we can probably to compare efficacy of two active agents, we know that either they can be tirzepatide could be inferior to dalaglutide, or we can see that tirzepatide and dalaglutide are equal in efficacy, or the third option could be that tirzepatide was superior to dalaglutide. So, in such a study in which we are comparing two active agents, it is very important that we fix the statistical analysis before the study is started. So, the criteria was fixed before the study was started, and this criteria for non inferiority and superiority was fixed based on the confidence interval and estimates of the hazard ratio. So here you will see that for non-inferiority to establish the upper bound of the confidence interval was fixed as less than 1.05, and in order to establish superiority, the upper bound of confidence interval was fixed less than 1. So here you see that the blue line is representing tirzepatide and the black line is representing dulaglutide. So we see that there is definitely decrease in 3-point MACE in tirzepatide as compared to dalaglutide. So again, because the confidence interval, the upper bound of the confidence interval was between 1 and 1.05, so it meant that tirzepatide was non-inferior to dalaglutide if we are talking about decrease in 3-point MACE. So we know from statistical analysis that if it is non-inferior, then again this would mean that it will be, if you are comparing tirzepatide to a putative placebo, tirzepatide would be superior to a putative placebo. So here again we see that tirzepatide, again this demonstrates that it is non-inferior to our this it is non-inferior, and but again it is superior to putative placebo. So if you look at all-cause mortality here, we know that tirzepatide definitely it is superior in reducing all-cause mortality as compared to dulaglutide. So if you look at the primary renal outcomes, we know that there is a 19% hazard risk reduction here if you compare tirzepatide to dulaglutide. And especially, the patients who were included in this group were those who had albuminuria or those who had worsening of renal functions. Again, here this shows the same thing, that high risk CKD population, that is those population which had high amounts of albuminurias or who had high levels of CKD stage 3 and 4. Again, tirzepatide shows 22% hazard reduction as compared to dulaglutide. So here you see that the secondary outcomes in terms of HbA1c and body weight, you would see that the HbA1c reduction was far more in the tirzepatide group as compared to the dulaglutide group. And if you look at the body weight, we find that, in the tirzepatide group, there was a marked reduction in body weight as compared to the dulaglutide group. So if we summarize this, that in a nutshell, the GLP-1 receptor agonists, they reduce 3-point MACE and they improve cardiovascular outcomes in type 2 diabetes. They improve glycemia. They help prevent renal complications in type 2 diabetes. And the novel indications for GLP-1 receptor agonists outside type 2 diabetes, such as type 1 diabetes, neurodegenerative orders, psoriasis, are being explored. And they are effective weight loss medications. So again, if you look at just in a nutshell, we go to the other new kid on the block, which is the SGLT2 inhibitors. So if you look at the SGLT2 inhibitors, which is the gliflozins, we know that they also demonstrate clear cardiovascular benefits, particularly in reducing heart failure and heart failure related hospitalizations, and across all diverse patient populations, including type 2 diabetes, chronic kidney disease, and including heart failure. So again, if you look at the key trials in type 2 diabetes, we have the EMPA registry, we have the CANVAS, we have the DECLARE TIMI, and we have the VERTIS trials. So if you look at the trial of empagliflozin, we have the EMPA registry outcome, which shows a 38% reduction in cardiovascular deaths and a 35% reduction in hospitalizations related to heart failure in type 2 diabetes. So if you look at the canagliflozin, the CANVAS program, which basically showed a 14% reduction in MACE with canagliflozin, then we have the DECLARE-TIMI trial, which basically highlighted reduced hospitalization due to heart failure and cardiovascular death with dapagliflozin. And then again, we have the VERTIS cardiovascular trial with ertagliflozin, which confirmed non-inferiority to placebo for MACE. So just a brief skim through that the EMPA registry trial. We know that this was conducted in 2015. It was a large multicentral trial and it was conducted on a large number of diabetic patients. More than 7,000 patients were included. And the primary composite outcome was death from cardiovascular causes, non-fatal MI and stroke. And we found that empagliflozin was associated with a marked reduction in cardiovascular mortality, non-fatal MI and non-fatal strokes. Also, if you look at the key outcomes of the empagliflozin trial, we found that the cardiovascular mortality, a dramatic 38% reduction in cardiovascular death was observed, a 35% reduction in heart failure was observed, and a 14% reduction in 3-point MACE was observed. I think here this figure will demonstrate to you in a better way that there was a 14% reduction in MACE, 38% reduction in cardiovascular death, 32% reduction in all-cause mortality, and 35% reduction in hospitalizations due to heart failure. This was followed in 2017 by the CANVAS trial, which was on canagliflozin. And again, more than 10,000 participants were there, and the data was integrated from two trials, and patients with type 2 diabetes and high cardiovascular risks were included, and these patients were followed up for a mean of 188 weeks. The primary outcome was again a composite of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal strokes. The same result we saw in the CANVAS trial, that the rate of primary cardiovascular outcome was much lower with canagliflozin as compared to placebo. The CANVAS trial was again followed by the VERTIS cardiovascular trial, which was in 2022. And this was the trial which was done on ertagliflozin. And again, we had a large number of patients who were recruited, more than 8,000 patients, and they were all diabetics with established cardiovascular disease. And the duration of follow-up of these patients was over 3.5 years. So if you summarize all this, you find that the cardiovascular safety and it was non-inferior to placebo in patients with type 2 diabetes, but we know that it did not show superiority in reducing major adverse cardiac event, but it did significantly reduce the risk of heart failure by approximately 30%. So if you want to sum this up, we know that ertagliflozin was found to be non-inferior to placebo for 3-point MACE. It definitely had heart failure benefits, but it had no superiority was met with regards to cardiovascular death or heart failure related hospitalizations. All these trials were followed by trials which were on dapagliflozin, and this is one of the landmark trial which is known as the DECLARE-TIMI trial. So in DECLARE-TIMI trial, we included a large number of patients, more than 17,000 participants were there. They were all type 2 diabetic patients. And out of these type 2 diabetic patients, 60% of the patients were high risk of atherosclerotic cardiovascular disease, and 40% of patients had established atherosclerotic cardiovascular disease. And they were randomized to dapagliflozin 10 milligrams versus placebo, and they were followed up for a period of 4.2 years. So here you would see that dapagliflozin basically causes a 17% relative risk reduction in primary composite outcomes of 3-point MACE. This trial was actually followed by the DELIVER trial in 2022. Now, the DELIVER trial was a trial which was conducted in over 6,000 patients, and it was conducted in those patients who had heart failure with preserved ejection fraction or mildly reduced ejection fraction. And again, we see that dapagliflozin, it reduced risk of worsening heart failure or cardiovascular deaths across all ages. And it had a consistent safety profile, and especially in the elderly group. because Deliver 2022 had 45% of the patients were diabetic, and about approximately 44% of the patients, they had an age greater than 65 years. And I think we should know that HFpEF and this HFpEF and HFpEF with who have heart failure with mildly reduced ejection fraction is very common in elderly population as compared to heart failure with reduced ejection fraction. So this was the first of the trial which was done in this kind of population. And again, because we said that 45% of our patients were diabetic, and similarly, 45% of our patients were those with above 65 years of age. So it was basically the trial was done on elderly people who had multiple comorbidities, polypharmacy, they had frailty, they had increased mortality risk. And again, we know that the elderly population is a special population because there's increased prevalence of atrial flutter, fibrillation, decreased BMI in this population, and they have a decreased left ventricular size, higher ejection fraction. So the DELIVER trial addressed this elderly frail population. All these trials were again followed by the DAPA heart failure trial, and the DAPA heart failure trial was actually done on a large number of patients, and there were more than 4,000 patients, and who had an ejection fraction of less than 40%. And we know that if you look at a pooled analysis of the DAPA heart failure,
I think Dr. Ishma has some connection issue right now. Her presentation got disconnected. Can we align with Dr. Ishma?
can you hear me now?
Yeah, we can hear you. You can start sharing your screen.
For sure, okay. All right, okay. Sorry for the interruption. I think if you compare and if you look at a shared pooled analysis between the DAPA heart failure and the DELIVER trial, you will find that there is a 14% relative risk reduction on all cause mortality and cardiovascular deaths as compared to a placebo. And here we also found that there was a 27% of relative risk reduction in heart failure related hospitalizations. So again, if you compare and if you combine the DAPA heart failure and the DELIVER trial, and we have a pooled analysis, just to sum it up, we know that basically it reduces cardiovascular death. There's a 14% relative risk reduction in cardiovascular death. There's a 10% relative risk reduction in all-cause mortality. And there is a total percent, there's a 29% relative risk reduction in heart failure related hospitalizations and 26% relative risk reduction in first hospitalization due to heart failure. And again, we know that if you combine DAPA on the standard of care in diabetes, there will be a 10% relative risk reduction in 3-point MACE, which includes cardiovascular deaths, MI, or stroke. So in this slide, I just want to sum up everything that if we put SGLT2 inhibitors, it is basically used for the prevention of heart failure in diabetic patients as evident in the DECLARE TIMI 58 trial. And those patients who had established heart failure, it was not only used for the treatment of heart failure, but it also reduced hospitalizations and cardiovascular deaths in patients who had established heart failure. And this was evident in the DAPA heart failure and the DELIVER trials, in which dapagliflozin was basically added to the standard of care, and 45% of the patients were diabetic in this pooled analysis. So I just want to sum up all these trials together. In 2018, we had the Declare TIMI trial, which was specifically done on type 2 diabetics. In 2019, we had the DAPA heart failure trial, which was done in heart failure with reduced ejection fraction in patients with and without diabetes. And then in June 2020, we had the DAPA CKD trial. And in March 2022, we had the DELIVER trial, which was done in heart failure with preserved ejection fraction and heart failure with mildly reduced ejection fraction. And 44% of the population was diabetic. And similar 44 to 45% of the population were patients who were greater than 65 years of age. And we found that for SIGA dapagliflozin, it provided a cardiorenal protection across all patients in these age group, and it basically causes a 36% relative risk reduction in patients with type 2 diabetes. So I think if we just combine whatever we said before, we have the EMPA registry outcome. Trials were done on empagliflozin. They basically showed a significant reduction in cardiovascular death and heart failure related hospitalization. Then we had the CANVAS trial, which was conducted on canagliflozin. It demonstrated reduced MACE, but it was noted to provide an increased risk of amputation. We had the DECLARE TIMI trial, which was done on dapagliflozin. It showed reduced hospitalizations due to heart failure and renal events, and it included a very broad population, including diabetics with multiple risk factors. Then we had the VERTIS cardiovascular trial, which was a trial done on ertigliflozin. It demonstrated non-inferiority for MACE, but it did not show us the same significant reduction in cardiovascular death as with other SGLT2 inhibitor trials. So if we look at a pooled analysis of all these trials which we have suggested, we know that heart failure benefits, the SGLT2 inhibitors, they have the strongest and the most consistent outcome across all trials in significant reduction in hospitalizations due to heart failure. If we look at MACE reduction, generally there is an 11% reduction in 3-point MACE, but benefits are more pronounced in patients with established cardiovascular disease. So if you look at the population type here, we know that benefits are consistent across type 2 diabetic patients, those patients with chronic kidney disease, patients with heart failure, both with preserved ejection fraction and reduced ejection fraction. And if we look at the mortality benefits, SGLT2 inhibitors have been associated with a lower risk of cardiovascular deaths and all-cause mortality. So here again, we see the effects of the SGLT2 inhibitors. They have effects on glycemia. They have effects on decreasing progression of renal disease. And the most important thing is that they have effects on cardiovascular disease. They will reduce 3-point MACE and hospitalizations for heart failure, and they will reduce death. So if we do a pooled meta-analysis of all the trials till now, we know that the SGLT2 inhibitors, they constantly reduce hospitalizations for heart failure by 23 to 24%, regardless of the ejection fraction and diabetes status. The mortality and MACE, it basically causes a 9% reduction in MACE. And these agents, they show consistent benefits in reducing CKD progression. And we know that the benefits, they appear across all classes independent of glycemic control. So I think going back to all our landmarks trial, we know that it's very important to reduce heart failure events, and it is very important to reduce cardiovascular events in diabetic patients. And we know that glucose lowering has minimal effects on reducing heart failure events, and it has minimal effects on reducing other cardiovascular events. So I think now the management of type 2 diabetes in light of all these trials would mean that we should shift away from a glucocentric approach to a more holistic approach which focuses on early cardiorenal protection. So this is which was actually highlighted in the 2024 ADA standards of care, that we have to individualize treatment according to our patients. Those patients who are at high risk of atherosclerotic cardiovascular disease, or those diabetics who have established atherosclerotic cardiovascular disease, a GLP-1 receptor agonist would definitely be the drug of choice, irrespective of the HbA1c or the level of glycemia. Those patients who have a tendency of which who have heart failure, or those patients who have CKD, the SGLT2 inhibitors is the drug of choice irrespective of the level of glycemia. Those patients who are morbidly obese or who have high BMIs, the GLP-1 receptor agonists like semaglutide and tirzepatide, they have proven beneficial effects in patients with type 2 diabetes. And again, if we look at the 2023 for the European Society of Heart Failure, the same thing it shows that the SGLT2 inhibitors basically show decreased risk of death from cardiovascular causes and all-cause mortality. So now we have a question of differential indications that when do we use GLP and SGLT2 inhibitors? So we know that any patient, any diabetic who has established cardiovascular disease, our GLP-1 receptor agonist would be the drug of choice. Any patient, any diabetic who has established heart failure or who has established CKD, the SGLT2 inhibitor will be the drug of choice. And any patients who have established atherosclerotic cardiovascular disease together with CKD or heart failure, we can combine both these agents. And these agents, they can be used in diabetic patients regardless of the level of HbA1c or the level of glycemia, and they should be started early in diabetic patients at the time of diagnosis. Thank you.
Thank you, Dr. Ishma, for the brilliant presentation and a very well summarized indeed that all the key latest CVOT trials mentioning that how we have changed our approach from being glucocentric now to outcome centric. A reminder to all the audience that you can post your questions with the name of the speaker you are asking the question in the Q&A platform, and at the end of all three presentations we will be addressing them if they have not been answered by your queries during the presentation time period. Now, I'm having a pleasure of introducing for our second speaker, which is Dr. Faryal Ishfaq. She's going to present a case which is immune checkpoint-induced diabetes. Dr. Faryal is working as currently as a fellow in endocrine service of Dubai Hospital, and she has multiple boards in internal medicine, and currently she's on pathway of obtaining the fellowship in endocrinology. This case she's encountered during her clinical service, and with some literature review and the interesting point about the case, she would like to share this with our audience. So this is a recorded lecture because she's currently on leave. So this has been pre-recorded, but she will be available for Q&A sessions. So we can start her presentation now.
Good evening, everyone. I welcome you all towards this cardiometabolic endocrinology section as of today from Young Leader Forum. Today I'll be presenting an interesting case focusing on the diabetes mellitus, an unusual diagnosis to think of during the clinic setting. So my today's topic is immune checkpoint inhibitors associated diabetes mellitus. These are the objectives for today's presentation. I'll start with the case discussion, a brief case discussion followed by the literature review for immune checkpoint inhibitors, pathophysiology, going back to follow up on our case, and multiple questions that came to our mind while having this patient in our clinic, and the take-home message will be following that. Let's start with our case. So we have a 52 years old female who is a diagnosed case of metastatic cervical cancer with having previous history of adjuvant chemo and radiotherapy in 2021. In 2024, month of June, she presented an emergency department with a complaint of generalized body aches and pains with fatigue and muscle spasm. On initial lab evaluation during her visit to emergency department, she was found to have a high blood sugar of 600 milligram per deciliter with negative point of care ketones. pH was 7.32. BICA was near normal. It was around 24.7 with normal plasma osmolality of 313. So initial presentation of patient with generalized body aches and pains with the lab parameters suggestive of hyperglycemia with no diabetic ketoacidosis and no element of hyperglycemic hyperosmolar state as evident from normal plasma osmolality and negative ketones. Going forward, because this patient came with acute hyperglycemic emergency, patient was admitted under care of internal medicine. As there was no evidence of acute hyperglycemic complications, patient was started on management with with IV fluids, hydration, basal insulin. She was found to have an HbA1c of 9.6%. She was seen by a diabetic educator. Detailed disease education was given regarding new diagnosis of diabetes. And as she came with severe hyperglycemia and new diagnosis, she was started on basal insulin on discharge. To be noted, this patient has no previous history of diabetes. This was her first presentation in emergency. She was discharged on a dual combination of dapagliflozin and metformin, along with insulin glargine and gliclazide 60 milligram. On discharge, she was referred to endocrine department for further management of diabetes. After discharge, within 3 weeks' time, she was seen in endocrinology clinic, and she was already on medications with a recent value of HbA1c. So she was continued on same regimen with the plan to follow her up in the next coming 3 months. During this point of contact, she did not bring with her any glucose recordings, so we did not get a clue that despite being on 4 hypoglycemic agents, how is her glucose profile going on. But as per her, she clinically felt really better in comparison to the presentation a month before. So her medications were continued with dapagliflozin, metformin, dimicron, and basal insulin glargine. After 3 months, as scheduled before, she was seen in November in the endocrinology clinic. Clinically, she mentioned that she's feeling much better than before, but she does had a complaint of some vaginal itching and some vaginal discharge, so her dapagliflozin was discontinued. During this point of contact in November 2024, she did not do her repeat blood test in terms of POCT glucose and HbA1c. So the only HbA1c which was done in June was reviewed 9.6. And based on her new diagnosis of around 4 to 5 months duration and SGLT2 was discontinued, she was started on semaglutide, Ozempic, in view of cardiovascular protection, along with continuation of other medications with basal insulin. Now, what happened after that? In each clinic visit, she was seen by diabetic educator. She was guided about the dose adjustment with glargine. She was doing very well when all of a sudden she lost follow-up after November 2024. She was given a close follow-up around 8 to 12 weeks to be seen in endocrinology clinic and further medication adjustment, but she missed many of her appointments until she was seen in clinic in July 2025, which is around 7 months from the previous encounter of November, and her HbA1c, which she did in December after her second clinic visit, but she did not seek any medical attention in between. So her HbA1c in December was 15.2%. So during her time when she lost follow-up with the clinics, she continued taking her glargine, dimicron, metformin, along with Ozempic, and she started to maintain her blood glucose low. On coming to the clinic in July 2025, when her blood glucose recording was seen, it was showing all the blood sugars of more than 500 and 600, which was a very alarming sign for a patient who is already on 3 hypoglycemic management along with newly started semaglutide. Blood sugars were more than 500 and 600. A blood workup was done immediately on that particular day. Her POCT glucose was more than 500 and POCT ketones were negative, but an HbA1c came out to be 17.0%. So in the current slide, if we see how did we start in August 2021, her baseline HbA1c of 5.4%. In June 2024, her HbA1c was 9.6%, which was the time of the diagnosis of diabetes. After 6 months in December, it increased up to 15.2% despite being on basal insulin and 3 oral hypoglycemics and with the addition of Ozempic a month ago. 6 months later, her HbA1c increased to 17.0%. So if we are sitting in a clinic setting and we are having a type 2 diabetic patient who claims to be compliant with her medications, and if we see the increment in the HbA1c, there is a persistent increase in HbA1c. During this 1 year, patient never presented with any hyperglycemic complications, be it diabetic ketoacidosis, be it hyperosmolar glycemic state. No, she did not present with, but her HbA1c was increasing and her SMBG was supporting the high HbA1c of around 17%. At that point of time, we extended the workup and looked into the C-peptide level because the first question came to our mind that why a normal type 2 diabetic patient with the conventional medications is not improving. So there might be something else in the diagnosis which we are missing. At that time, when she was on glargine and other medications, a C-peptide level was done. I will consider it as a baseline C-peptide level. It came out to be low, 0.26. And although antibodies which were done, including insulin autoantibodies, islet cell antibodies, and GAD, they all three turned out to be negative. Because the first consideration came to our mind that could it be autoimmune diabetes which we are missing and patient is not responding. Now, in July 2025, when we saw the blood results of HbA1c of 17%, we stopped her semaglutide, we stopped her oral medications, and started her on basal bolus insulin regimen. She was started on glargine 26 units and Lispro 12 units TDS, which was a weight-based dose of 0.4 to 0.5 units per kg. She was given a very close follow-up with diabetic educator, and detailed counseling was done with the patient regarding the change of treatment. Now, what are the questions triggered in the mind during the most recent consultation in July 2025? It's a very usual case in the endocrinology clinics to see a patient with a newly diagnosed diabetes or uncontrolled type 2 diabetes or type 1 diabetes. What was special in this case? Somebody who is having uncontrolled hyperglycemia, but not coming with hyperglycemic emergencies and not even improving on the medications. So first question was, is the diagnosis correct? Are we dealing with the typical type 2 diabetic case with the progressive failure of beta cell function resulting in the failure of the medication and requirement of basal bolus? Could there be another cause for this diabetes which is missed either in the history or patient did not reveal some important information or we did not ask for? The third question came, if it is something related to some drug which she has been on as a part of chemotherapy, is there any time range to develop diabetes mellitus after the drug intake or no? If that is our top differential, how do we make the diagnosis of that? And is checking C-peptide level baseline while patient being on glargine insulin, is it the right way to check the C-peptide level? This was the cascade of questions that traveled through our mind while being encountering this patient during that particular clinic visit. If it's a drug-induced diabetes, how we are going to manage? And if the underlying drug which is responsible for this particular clinical presentation, should we continue or no? And what is the long-term outcome of the diagnosis? So it's a cascade of questions which was running through the mind when patient asking multiple questions. Doctor, what's my diagnosis? Why I'm being shifted to 4 injections a day all of a sudden? What do you think? What could be the reason for that? So let's start with the first question. The question is the diagnosis correct? So in somebody in this age group in 40s and 50s or early 60s, if somebody is presenting with an average HbA1c of 8 to 10 or 11 without any ketosis, without any HHS, our first impression is most likely to be type 2 diabetes. The second impression could be latent autoimmune diabetes of adults that could have an underlying positive autoimmunity evidence and usually do not present always with DKA, as unlikely type 1. And the third consideration was, could there be any interfering agent in the patient's medication that could cause diabetes? Because as we said in the first slide, that she's a case of metastatic cervical cancer and has been on chemoradiotherapy with a failure to response. So when we dig more into the history, actually in the mid-2022, patient was started on immune checkpoint inhibitor named pembrolizumab. So it's one of the programmed cell death PD-1 inhibitor, pembrolizumab, which has been approved for the treatment of multiple cancers, metastatic cancers over the last 12 to 14 years. The first time it was approved in 2014, along with nivolumab for the treatment of melanoma, and since then its use has been extended in multiple malignancies. The second consideration why we are not able to control conventional type 2 diabetes with traditional oral hypoglycemic drugs being insulin on board as well. Are we really missing something? So this was the chronological order for this particular patient. Once she finished her conventional chemotherapy for cervical cancer, after 2 years, she had a recurrence of the disease, and the tumor board meeting had decided to put the patient on pembrolizumab. If we remember, the first HbA1c was in 2021. At that time, her HbA1c was 5.4%. She was never diabetic. And in addition, she had no family history of diabetes as well. And she was never been on very heavy dose of steroids to say that it could be steroid-induced hyperglycemia or new diabetes. So she was started on pembrolizumab in September 2022, and the diagnosis of type 2 diabetes based on the HbA1c of 9.6 was made in June 2024, which is roughly, if we could say, it's 16 to 18 months from the start of the therapy. Now, let's talk about what do we have in PD-1 and PD-L1 inhibitors, and how does it work in the immune checkpoint axis. So we all in our bodies have immune checkpoint axis. This is called the brake system. These are the brakes in the immune axis which stop or inactivate the T cells and to create an unnecessary cascade of the immunity. So if you look on the left side of the screen, I have highlighted the T cells. On the base of T cells, there are intrinsic PD-1 receptors. These are called program death receptors. Normally, these PD-1 receptors are coupled by PD-L1 ligands, and it acts in the inactivation of signal of the T cells. T cells become dormant, and it does not cause any autoimmunity. So what happens as the tumor cells grow in the body, the tumor cells with the passage of time have become more and more smarter. So what they have tried to do, the tumor cells are expressing more and more PD-L1, which is programmed cell death ligands. So what do programmed cell death ligand do? When it binds to the PD receptor on T cells, it causes the inactivation of T cells. So the tumor cell escapes from the death by the T cells. So our immune system becomes dormant when the tumor cells PD-L1 expressing connect to the T cells PD-1, and the immune system becomes a bit of escape from the immunity, and the tumor cells get an escape from the death, which is called an immune escape. As we all know that we have been approaching, and we have in a modern era where new medications are being launched every couple of years or within a year. So the new medications which are actually the immune checkpoint inhibitors. In the second picture on the right side, in the rectangle, if we see that if we put the inhibitors to those PD-1 and PD-L1 ligands, they do not let tumor cells bind to the T cells and causing activation. So inactivation, sorry. So if we are putting the antibodies, we are giving the inhibitors, that the reaction does not happen between PD-1 and PD-L1, which was inactivating the T cells. So by giving the inhibitors, we are giving the command to T cells to remain active, to detect these tumor cells and kill the tumor cells. So if we understand the physiology, it's easier to understand the pathophysiology in this particular concept. Now, once we talk about the PD-1 and PD-L1 inhibitor, see, we are trying to manipulate with the immune system. So these inhibitors and these receptors are not linked to T cells in one organ. They are present all over the body. So when we are giving inhibitors, we are creating an immunity to our normal human body cells. As a result, we get immune-related adverse effects. For example, if these medications are interacting with the T cells within the gut, and we are activating the T cells over there, so there's an immune reaction ongoing, which can end up having a colitis or a gastritis, or in case of thyroid, it can cause thyroiditis, or it can initiate a Graves' disease. All kinds of possible immune reaction can happen, being it excitatory or stimulatory. Whenever we are grading these immune-related adverse effects, they are grading from grade 1 to grade 3. And when we talk about which one is more potent in terms of side effects, which one is more dangerous, so we are basically having two types of receptors, PD-1 and PD-2. If we are giving PD-1 inhibitors, not the ligand, the receptor inhibitors, so it's blocking both PD-1 and PD-2 receptors, and we are getting an extensive effects all over the body. So the side effects are more with PD-1 inhibitors. The effect of complete response or pathological response and disease-free survival is also with the PD-1 is more because it has more receptor distribution. Now, if I conclude this particular thing, that if we are giving only PD-1 inhibitors, we are blocking both the cascades, PD-1 and PD-2 ligand. But if we are giving only PD-1 ligand inhibitors, P2 pathway remains still active. That's the reason that number of side effects are low. That's so the efficacy of it as well. And it was beautifully explained in this systematic review. The more the side effects of any particular drug in terms of immune related, we expect a better disease-free survival. Now, once we talk about that our patient has likely, because I will come to it about why we are saying it's a likely diagnosis of immune checkpoint inhibitor diabetes, was the method of diagnosis was correct or not? Now, there are different classifications of immune checkpoint inhibitors, starting with CTLA4, anti-PD-1, PD-L1, and they are all notorious for their immune-related side effects, specifically endocrine side effects are there. So 95% of the cases of immune checkpoint inhibitors happen because of PD-1 inhibitors. And the overall incidence in different studies and different literature review varies from 0.9 to 1.9%. The incidence is small, but pathology or the clinical picture can be life-threatening or dangerous, or can be a lifelong replacement of the insulin is required. So because the incidence is less, it does not mean that it's something that is really negligible not to focus on. One more thing that was beautifully explained by Özkan, that if there is a combination immunotherapy of, for example, anti-CTLA4 and PD-1 inhibitors, the risk of developing autoimmune diabetes increases. In the next couple of slides, we will see why these immune checkpoint inhibitors are causing autoimmune diabetes at this spectrum. So there was one question that came to our mind, that if our patient is falling between 16 to 18 months of time after the starting of immune checkpoint inhibitor, which was pembrolizumab to be specific in our case. So as per the literature review from this particular slide, you can see there is a lot of heterogeneity. Nobody has a specified exact number of months and days that within this period, if patient is developing diabetes, yes, it is drug related. And after this, it's not drug related. We do not have a particular time cutoff or to say that it cannot be related to drug after this point of time. The first one by Özkan, he has mentioned that it's called a late onset diabetes from administration of immunotherapy. It can happen anytime from 5 days to 23 months of duration. It is characterized by rapid islet cell destruction and initially a low C-peptide levels. The second study by Garcia says that average time of diagnosis can vary from 7 to 17 weeks. And the third study from Velkarkar says the time from drug administration could range from 1 week to 5 months. Means there is a lot of heterogeneity. We cannot be sure at any point of time. So whenever we are evaluating any new patient with diabetes, we should keep our differential open, that it could be related to any drug which patient has recently received or at least in the last 2 years. The third question came to our mind that could be a dose-related effect because patient has received it 2 years ago or 18 months ago. Does the dose-related effect explains this type of pathogenesis or no? So there has been no significant relationship identified between the number of doses. Rather, there are some case reports where patient developed a life-threatening DKA episode presenting as a new diabetes even after the first dose of pembrolizumab. So it does not correlate necessarily. Now what happened to the pathogenesis of why it is caused by ICI? Just like the tumor cells remain more with PDL1, they express more of ligands. In our islet cells, in our pancreas, there is overexpression of PDL2 and PDL1 receptors. So whenever we are giving blockage, we are causing the direct destruction of these beta cells. There is inflammation, there is increased autoantibodies to insulin by unknown mechanisms. There is excessive T cell activation and proliferation, and all of these will end up in the beta cells destruction. Whenever the beta cells or islet cells are destroyed, they release this chemical GAD in our bloodstream, which is not supposed to be in bloodstream. So body starts to make anti-GAD antibodies, which we usually check in type 1 diabetic patients. The same is being explained by Dr. Irani in this particular pathogenesis mechanism, that normally if the T cell is inactivated under the effect of PD-1 and PD-L1 ligand, it remains inactivated. There is no harm in the pancreas. But if it's a checkpoint inhibitor associated diabetes, because of the checkpoint, there is overactivity of the immune system by activated CD8 cells and causes destruction of beta cells. Now, what is the characteristic of it? We all know that in few cases, or in most of the cases of type 1 diabetes, there is autoimmunity and there is a honeymoon period is there where patient can be off insulin or on a very minimal doses of insulin. The contrary happens here. In checkpoint inhibitor-induced diabetes, a very rapid decline and very high frequency of ketosis as well, because the beta cell function is declined all of a sudden after the triggering agent. Still, there is no consensus where we should put this specific type of diabetes, either as a type 1 diabetes, because patients are going to be requiring insulin, or fulminant type of diabetes. It is still not classified yet because it has a bit different pathophysiology underlying with sharing features of both 50-50. Now, they looked into the risk factors for this particular type of side effect from this drug or any of the immune checkpoint inhibitor. There are no pinpoint risk factors, but if somebody is having family or personal history of autoimmune diseases, there are other immune related side effects like thyroiditis, colitis, gastritis. These people are more prone to have immune checkpoint inhibitor diabetes. And if there is a combination of immunotherapies is there. Now, the next two slides, they are more or less the same from two different resources, doing the differentiation between immunotherapy-related autoimmune diabetes in the left side and the right side type 1 diabetes. If we look into the clinical course section, here they have tried to explain that could be median 12 weeks after the immunotherapy's treatment. C-peptide can be low, but on the contrary, in type 1 diabetes, there could be a honeymoon period and C-peptide can be normal in the first 3 to 4 years of the diagnosis. Coming to autoimmunity, it can be negative in 60% of the cases, but it's positive in 90% of the cases with type 1 diabetes. There has been extensive workup being done to look into the genetics of the patients who are developing immune checkpoint inhibitors, diabetes, and they have found some association with different HLA halotypes over there, but it's not as common as the type 1 diabetes. The same it is explained by ADA in 2023. ADA has labeled this specific diabetes as checkpoint inhibitor associated autoimmune diabetes, and they have mentioned the difference in presentation in the two different groups. In checkpoint inhibitor autoimmune diabetes, the DKA is the presenting feature in at least 69.7% cases. On the contrary, in the children, it's only in 39% of the cases. Same goes for autoantibodies. 40% of the cases can have autoantibodies positive, less than 60% negative. But in type 1 diabetes, it's around 90% of the patient have a positive positive autoantibodies present. Now, when I said initially that the baseline C-peptide was low in our patients, so a question just passed by that, is it the right time to check the C-peptide level in somebody who is having chronic hyperglycemia? Why do we say that we should not check the C-peptide levels in a patient who comes with DKA? Does it affect our diagnosis? In our case, patient is not in DKA, patient is not in HHS. She's a walking ambulatory patient, but does have a chronic hyperglycemia. Should we check C-peptide in this patient or no? So here comes the concept of glucotoxicity. When we have a prolonged or chronic hyperglycemia for longer period of time, beta cell function is usually suppressed, which can give us a falsely low level of C-peptide. That's the rationale behind not checking C-peptide levels in patients who are having acute DKA, acute sepsis, because the level is suppressed. So having a low C-peptide level in an acute hyperglycemic situation does not equalizes to beta cell failure, at least the permanent beta cell failure. It's a very complex mechanism which were explained by Dr. Kaufman. He says that if there is a chronic hyperglycemia, so endoplasmic reticulum within the islet cells and the mitochondrial membranes get affected. There is a very delicate balance between the release of insulin from the endoplasmic reticulum secretory molecules into the stream in response to high glucose. So when the glucose stays in the blood for a very long period of time, so endoplasmic reticulum capacity outweighs. It cannot produce that much insulin for longer period of time. So it enters into a cascade which is called unfolded protein response, which ultimately ends in the cell death and apoptosis of beta cells. So if the glucotoxicity remains for a very long period of time, we expect beta cell function and beta cell mass to be reduced. C-peptide, there are different guidelines regarding the check on the C-peptide. What is the optimal timing? What is the optimal way to check it? Whether patient should be fasting or non-fasting. So there are three main points that I could end up in, that it should not be checked within 2 weeks of acute hyperglycemic emergency. It should not be checked if patient has hypoglycemia in last 12 hours, because definitely C-peptide is going to be on the lower side. And it is cleared in the kidneys, so it is most of the time it's increase in end-stage renal failure, so the results are not reliable. Now, coming to the C-peptide level, as we said that we cannot check it in acute hyperglycemia, so what's the right time to check the C-peptide level to reach a diagnosis is that once the patient is optimally blood glucose controlled, patient is on basal bolus insulin, there are no guidelines about it when to stop the insulin, which one to stop to assess the C-peptide level. But it's generally, it is recommended that the lowest correction doses of insulin will not affect the C-peptide levels. There is no particular duration which is mentioned. I couldn't find any particular guideline or source mentioning the number of hours to avoid the insulin before checking the C-peptide. But if the C-peptide level is critically low, less than 0.2 or 0.1, we should not stop insulin in these patients for repeat assessment, because the risk of DKA is there. Now, what does the guideline say regarding the use of immune checkpoint inhibitors and how we should monitor our patients to avoid this complication? So American Society of Oncology recommends that if somebody develops autoimmune associated diabetes with immune checkpoint inhibitors, until the glucose level is controlled, we should keep the ICIs on hold. And the patient has no evidence of ketosis and serological evidence of type 1 diabetes. After that, once the diabetes is managed, there is optimal control, we can resume the ICI as per the need and as per the MDT decision. Now, the second point is the most important one, how we can prevent it or how we can early detect this particular complication. They recommend to check the blood glucose level at the baseline with every treatment cycle for at least 12 weeks, and after that, every 3 to 6 weeks. It will give us an idea that if a patient is going to develop hyperglycemia, we should initiate the workup for that particular condition. It has also been suggested, it is not recommended yet, the third point, but it is suggested that if a patient is having type 2 diabetes and is going to be started on immune checkpoint inhibitors, it is suggested to check their autoantibodies levels before starting the treatment. In case if patient is having worsening of glycemic control during the treatment part, it should not only be mistaken that yes, it is type 2 diabetes which is worsening. That's the point which demands the repeat work of autoimmunity and check, has it converted from negative to positive? Because if it has changed antibodies from the beginning, if they were negative and now they have become positive, it means now it's autoimmune induced diabetes. So the conventional treatment of type 2 diabetes is not going to work. So that's a suggestion to do a risk stratification before starting the ICIs. This is a picture from ADA 2023 Diabetes Care, where they have mentioned the same thing. CIADM is checkpoint inhibitor associated autoimmune diabetes. It's a beautiful systematic review of around 1,200 papers, and they have looked into 192 patients, and they come up with the diagnostic criteria for this particular condition. So diagnostic criteria demands basically two things in the middle column. The first one, there should be documented hyperglycemia, and the second, there should be an evidence of insulin deficiency. Now, to put the patient and say that it's an insulin deficiency of no, we already discussed that how we can optimize the patient and then we can proceed further from there. They had chosen a cutoff of C-peptide of low at least 0.3 to 0.4 or even less than that. And they said in the first presentation, at least 91.6% patients had low C-peptide level. And when they were followed up over a couple of months, 100% of patients had insulinopenia in terms of low C-peptide levels. This is the recommendation for American College of Clinical Oncology regarding the grading of the immune-related adverse effects, including diabetes, where they say that if there are moderate symptoms, we can consider to stop the checkpoint inhibitor until we optimize the glucose. But if it's really severe symptoms, more than 500 with ketoacidosis or other abnormalities, we should keep it on hold and optimize, and we should go back until the glucose is controlled. Now, what is the treatment recommendation in this particular situation is that early insulin therapy should be considered in all the patients with a diagnosis of CIADM, even if the initial C-peptide is low, until subsequent C-peptide testing can be done to confirm the diagnosis. Like in our case, the first C-peptide was low. The patient could be under the effect of glucotoxicity at that time. So it did warrant to repeat the C-peptide level once patient is optimized with acceptable blood sugar controls, and then we can make a diagnosis and think about the further insulin therapy. So what happened to the different patients and the follow-up in the different case series and case reports? All of them invariably required insulin administration. Many of them were given a trial of steroids, just like other immune-related complications of skin on colitis, that they do respond very well to steroids. But in case of diabetes, no, they never responded. So ultimately, all of them were continued on insulin, and they could not be weaned off the insulin. Now, coming back to our patient, and the starting point is that in October 2025, so July 2025, we had a questionable diagnosis, and we put that it could be a drug-induced autoimmune diabetes, and we had shifted the patient on basal bolus regimen. So around after multiple visits with diabetic educator, and then an in-person visit on October 2025. Patient attended the clinic. She was doing very well. Rather, she started to get some hypoglycemias now. Her blood sugar was dropping at least to 30 to 40, and she was really symptomatic on that. Most of her blood sugar readings on SMBG recording were between 70 to 160. None of her postprandial reading exceeded 160. So her insulins were adjusted at that time. She was educated about the hypoglycemia precautions and treatment, and she was emphasized on when to come to the hospital to emergency. On the follow-up visit, what we had done, because patient was on basal bolus insulin, we gave her a very small dose of bolus insulin a day before with the dinner, shifted her nighttime basal insulin in the morning to check at least a C-peptide level. And here we can see the C-peptide level, which is quite out of the glucotoxicity window now. So we can say it's a true insulinopenia depicted by low C-peptide level. And at the time of checking of C-peptide, it should always be paired up with fasting glucose to mitigate the effect of underlying hypoglycemia. That if there is any hypoglycemia, it will give us low C-peptide level. But in her case, fasting glucose level was 109. And the repeat HbA1c over a period of 4 months' time, it was 7.6%. If we say, yes, it is a significant drop from 17% to 7.6%, but I think that was needed with the basal bolus insulin regimen and to see the response, how the patient is actually doing. So we ended up with final diagnosis. This diagnosis does not have a particular category. In some papers, they call it as immunotherapy-related diabetes, IODM. And in ADA in 2023, labeled it as checkpoint inhibitors-associated autoimmune diabetes. So let's conclude our presentation with take-home message. Not every typical or conventional type 2 diabetes is type 2 diabetes. We have to keep our differential very open, very broad. And it's always of great importance to look back into the history before labeling the diagnosis. Regular blood glucose monitoring and to keep the low threshold for diagnosis is very important when the patient is on any immune checkpoint inhibitor. Patients' education is of utmost importance. It has always been, the third statement is being recommended by ADA that it should be added to the consent procedures or the written consents for the patient before starting the ICI, that they should be educated about hyperglycemia and ketoacidosis. So they will be easily presenting to emergency if they suspect any of the symptoms. Now, patient education should be addressed before initiation of the therapy and the decision for continuation. See, here we are dealing with a subject which is very having a delicate balance. If somebody is going to develop the diabetes, on the other hand, if we stop the ICI or immune checkpoint inhibitors, there is a chance that there will be worsening of metastatic disease. So this area is of quite a delicate balance. It needs an MDT decision between the oncologist, between the endocrinologist, and the patient decision in the beginning, okay? Because patient needs to understand that withholding the therapy to manage the diabetes can have some adverse effect on the baseline disease as well. So it's always an MDT decision to decide about. American College of Oncology has given some considerations about mild, moderate, and severe risk, but as we always think about the patient priority regarding the medications, regarding the choice of the treatment, patient should be given a priority over the hair as well. And they should be given a consideration before stopping the therapy with immune checkpoint inhibitors. Lifelong treatment with insulin is usually the main pillar of the treatment. Most of them, they develop permanent autoimmune diabetes. In all the reported literature, they have been on lifelong treatment with insulin, and they have not been able to shift to either oral hypoglycemics or discontinue the insulin treatment. So this should be patients understanding from the very beginning that the cause of the diagnosis or the diabetes is the underlying drug, and it's a permanent damage. It might never recover. So they should be very compliant with the insulin. These are the references for today's presentation, and thank you so much.
Thank you so much, Dr. Faryal, for sharing of this interesting case as well as the comprehensive literature review. It was very fruitful to have the discussion and raising the awareness about the immune checkpoint-induced diabetes. Now move on to our third speaker without any delay. This is Dr. Nada bin Haris. She's a very well-known figure in lipidology. And today's topic is about precision lipidology in practice, translating latest guidelines into risk stratification and treatment targets. Dr. Nada is consultant endocrinologist in the Dawam Hospital in Sheikh Tehnoon bin Mohammed Medical City in Al Ain, UAE. She's assistant professor of medicine in United Arab Emirates University, and she's diplomat American Board of Clinical Lipidology. Dr. Nada, start sharing your screen and having a very warm welcome to Young Leader Forum again.
Thank you very much, Doctora, for this nice introduction, and good afternoon. I know we are a bit behind the schedule, so I will keep this brief and focus on the key message. Okay, Assalamu alaikum. So today I will the introduction or focus on practical guidelines based on decision making. So I have no relevant financial disclosure. This presentation is based on the current evidence and major international guidelines.
Dr. Nada, can you kindly make it presenter mode?
Sorry, it's not in presenter mode. I think there is more than one. Just wait a minute. What about now?
Perfect.
So by the end of this talk, my aim is to make lipid management simpler, more easier and more applicable to your daily clinical practice. We all know the guidelines are there, but the real challenge is how to apply them effectively in real world patients. So today I will focus on bringing or bridging the gap between guidelines and clinical practice. And I will focus today on the latest guidelines, which is 2026, which has been published very recently, 10 days ago in March 2026. Importantly, this is not just an update. It replaced the old guidelines, which is 2018 cholesterol guidelines, and represent a comprehensive document of more than 120 pages. More importantly, it reflects a shift in how we approach lipid management toward risk-based goal-directed and individualized care. Given the size and depth of these guidelines, I will focus on the key practice-changing concepts that are most relevant to our daily practice. So traditionally, lipid management has been centered around LDL. So LDL centric and LDL remain a key therapeutic target. However, LDL alone, we will see in this guideline, does not fully capture the cardiovascular risk. So to start with this concept, which it is emphasized in this guidelines, that LDL is not sufficient. Don't look to LDL alone or LDL cholesterol. So for example, if you have two patients can have the same LDL, but very different number of their atherogenic particle, and therefore they are very different in their cardiovascular risk. This is why the new guidelines move beyond LDL and integrate many other enhancement factors like ApoB, which reflect the number of atherogenic particles, and lipoprotein A, which reflect genetically driven risk. In addition, we know coronary artery calcium scoring, which it was just an enhancer factor in the old guidelines. Currently, it's present in this guideline more strongly integrated to the refined risk, especially in patients where the risk is uncertain. And we will see here that the key message is LDL remain important, but it's not longer sufficient. We are moving toward a more precision-based approach to cardiovascular risk assessments. So to start on this, maybe I put just clinical question about patient A and patient B. Both of them have the same LDL, which is 3 millimole. Do you think both of them have the same cardiovascular risk or no? This is what the guidelines emphasize. So to start with this, let us see here. I bring this, which I try to make it simple. I create this diagram to see, for example, let us start with patient A, who LDL is 3, but we have seen here, as you can see, the formation of lipoprotein, and then we have LDL particle or lipoprotein particle. So as we see here, LDL particle, we can see this, the lipoprotein, this is a portion of triglyceride, and this is the LDL cholesterol. So it is the cholesterol content in the LDL. This is the cholesterol in the LDL, and this is the cholesterol in the LDL. And that's how we measure the LDL cholesterol. So it is the cholesterol part in the LDL particle. So this patient have cholesterol part in the LDL is equal to other patient who have a lot of particle. See this, how many particle do we have here? So here we have a lot of LDL particle. And when we go back again and measure the LDL, the cholesterol part in their LDL, it will be the same. So this part, the green part, plus this, plus this, plus this. So all will give us 3 millimole, similar to the previous patient. But you can see the difference in the number of particles. So here we have only 3 particles of the lipoprotein containing ApoB. And this here we can see the ApoB particle, which it is attached here to the receptor in the liver, and that's how it's being recognized and degraded. So here we have 3 particles of lipoprotein or the LDL, And here we have, let us count, 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9. So do we think both of those patients have the same cardiovascular risk? And that's which I need to clarify. And this is emphasized very clearly in these guidelines. So same LDL does not mean same cardiovascular risk. And that's why the ApoB particle number is very important if you are looking for patient who's still developing a risk or cardiovascular event why their LDL is still low, and that how it is make your it's matter when you look for it and look for ApoB particle. So atherogenic particle are present, which is reflected by ApoB. When you have more ApoB, they are more atherogenic. So patient B is more atherogenic and more higher cardiovascular risk than patient A, while both of them have the same LDL cholesterol measurements. So this is the conceptual shift in this new guidelines. LDL remain essential, yes, but not sufficient alone. Risk is driven by atherogenic particle number, which it is ApoB, and in the guideline they keep saying atherogenic particle burden, but I put a number to be clear for everyone. So number 3 about lipoprotein A. So in addition, lipoprotein A reflect genetically mediated risk that is independent of LDL. So even with normal LDL number, we think that this patient he doesn't have any risk, but no, with high lipoprotein A, so these patients is genetically have higher risk. And also coronary artery calcium scoring help us to refine risk when there is uncertainty. So if you are uncertain about those patients, you need to request coronary artery calcium, and then you can have the answer. So overall, we are moving from simple LDL based model or approach to the more precious and individualized cardiovascular risk assessments, and this is very clear in this guidelines. So why you think this is matter? Atherosclerotic cardiovascular disease remain the leading cause of mortality worldwide. And even when we control LDL aggressively, significant residual risk still persists, which tell us that LDL alone is not capturing the full picture. And also traditional risk models, which we are usually do it, is tend to underestimate risk, especially in patients with factor like elevated lipoprotein A, metabolic disease, or subclinical atherosclerosis, especially in primary prevention. When we apply those traditional model for calculator, we saw that those three important elements has been not been calculated. So that's why we are underestimate the risk of this patient. As a result, many patients are either undertreated or sometimes even overtreated. So misclassification is been a big issue and problem. So again, all three patients have the same LDL here, but clearly their risk is not the same. You can see patient 1, patient 2, patient 3. So what actually determine the risk? We know that LDL are the same. Is this enough? So no. So what you need to do next? So risk determined, which it is clearly addressed in the guidelines, which if I want you to remember one thing from my presentation, I want you to remember those 3 lines. So ApoB reflect particle number, which it is reflect residual risk. Lipoprotein A, genetically mediated risk, hidden risk. If you not ask and you not send the blood work for lipoprotein little a, you will not know that. And calcium artery scoring reclassify the risk, and you can see the plaque burden. So here the patient with ApoB will have a low ApoB number in comparison, you see that there is no event risk. But here he have with high ApoB, he have event risk, and even when you go for lipoprotein little a, when it is elevated, again you are worried more about event. And for calcium RT scoring, when you are not sure about that and you request, and if it came high, so this patient have a higher risk to develop cardiovascular events, and we will touch on this. So same LDL does not mean same cardiovascular risk. So when should I use ApoB in practice? So usually we use it when there is discordant profile between LDL, which it is normal to us, and then you see high triglyceride, persistence high triglyceride, and you think about those patients have overproduction of VLDL particle. So usually overproduction of VLDL particle can cause a lot of abnormals, or you can see a lot of ApoB production is there. So at this time, you need to request ApoB. Diabetes, because diabetes is one most common cause of overproduction of ApoB from the liver. Metabolic syndrome, obesity, insulin resistance. So reduce residual risk despite control LDL. You have patient develop still event while their LDL is 1.8 or 2, and still they develop MI or stroke. So at that time, you need to request ApoB, borderline or intermediate risk patient. So this concept is there from the old guidelines, but it's not that addressed very clearly. But this time you cannot do any calculator ignoring those ApoB or lipoprotein or calcium risk scoring. So coming to the lipoprotein A, which it is, what is lipoprotein A? It's completely different from LDL and ApoB. It's genetically determined, almost fixed from birth. It's there, so that's why you need to check it only one time. So when it is high, the patient carry lifelong risk regardless of lifestyle. This is why that in 2026 guidelines now recommend measuring it at least once in all adults. And that's changed from the last guidelines when they are saying you measure lipoprotein little a in certain conditions, like a very aggressive family history of premature heart disease and blah, blah. There is a lot of points. But nowadays, no, you don't need anything. Even a patient came with thyroid disease, you need to measure lipoprotein little a. That which guidelines said it need to check once in a life. And clinically, it's help explain some things we see often, patient with normal LDL, but still developing events. So lipoprotein little a is essential, the hidden inherited risk that we would otherwise miss in our clinic. Again, going back to lipoprotein, it's complete. As we said here, the risk when it is above 125 nanomole or equal to 15 milligram, that means increased ACVD risk. Risk is continuous, and there is no safe threshold. In practice, it's lead to residual risk despite optimal LDL support, earlier therapy, more intensive LDL lowering, use of calcium artery scoring for reclassification of these patients. So lipoprotein little a is the risk you cannot see on standard lipid panel. And when we want to know how the paradigm shift of the guideline from 2018 to 2026, I put here in this table the main difference between both guidelines. In 2018, it's LDL focused. In 2026, it's more particle-based, ApoB. Here we use the pooled analysis to do the cardiovascular risk assessment scoring for patients with the primary prevention who do not have an attack before. But in this guidelines, recommendation is to use the prevent risk scoring, which it is a new modules. Also, I will touch on it in the next slide. Here, treatment also only to target bile heal target plus the absolute percent of reduction in the LDL is matter on these patients. Here for calcium scoring is optional, same like lipoprotein little a is optional in some cases, but nowadays in 2026, no, it's central and it's need to be done. Lipoprotein little a need to be done for all patients, at least one. So beyond LDL and biomarker, risk prediction itself has evolved, as I said. And here I highlight only three, maybe you can see, or four things. And the difference between the pool analysis, which was before in 2018, and the prevent now, what the difference between both of them? First, prevent expand beyond 10-year risk to include lifetime risk, while here it's only 10-year ACVD risk. And second, it reduced the strong age dependency we saw with the PCA analysis of risk. It's strong age dependence, may underestimate young. Usually we do it when age above 40, but here improve age calibration. So you can do it for most of the age and it is lifetime risk is there in the prevent analysis. Focus on ACVD event, MI, and stroke only, but in the new risk calculator, it's broader outcome, so ACVD and also heart failure. So limited variables only include some variables, lipid, blood pressure, diabetes, smoking, while here they include also a metabolic factor, BMI, CKD. So as we know, it's driven from old cohort. Here has been updated to the new populations. As we say, a lot of under or overestimates by using the old guideline, old risk predictors modules, while now there's improving calibrations and short-term risk prediction, while here we have longer-term prediction, population-based estimation, more personalized risk estimations. So this is not just a new scope, it's more comprehensive and biologically relevant way to understand the risk. So this is which also I like it in this new guidelines. So prevent expand risk from static to dynamic personalized assessments. So what is the prevents? Just to, in one slide, I can say that it is more younger population has been included. It's from age of 30 to 79. As we know, all of us, like the same old model, it's primary prevention population, so no established ACVD we can do, and it's useless to do a prevention or calculator score. Used before treatment decision, not intent for non-ACVD or severe hypercholesterolemia, because we know LDL above 190 or 4.9, you need to treat right away. You don't need to form the calculations. Severe or familial hypercholesterolemia, you need to treat right away. So this is concept keep carrying also in this new guidelines. Clearly high risk patient requiring treatments. Prevent is for uncertainty, not for obvious disease. So what does prevent actually give us? It's 10 risk and lifetime, and it is serve as a starting point, not a final decision as we do before. Before, it's give us like less than 5%, 10 to 15% more. So it's give you, and then based on this percentage, you will decide to start or no for the treatments. But in this, no, it's just a starting. When you know the calculator, how much percentage of this patient, then you need to still to add the other determined factors like ApoB, lipoprotein A, and those stuff. So you cannot use the number by itself like before. Does not fully capture biological or subclinical risk. It's not included in their calculator, but you need to add it. So that's why you need to refine those number, which you get it by calculator by adding ApoB, lipoprotein A, and calcium scoring. So it's give us a number, yes, but still you need to refine that. So here are the example, what you will get by applying this prevent calculation: low, less than 3%, borderline from 3 to less than 5%, and intermediate 5 to less than 10, and then above 10. So still you're getting a number. What the difference? But here is It's not the end of the case. Not mean low risk that patient that not need the treatments. No. So low risk, but where you need still to request, as I said, dose ApoB, and if it came high, so still you need to start treatment. So low risk, do not assume low biology. Hidden risk may still be present, so that's why you need to request them. Borderline risk, decision zone. Biology determines management. So here already it's you need to start and think about managements. Intermediate, so treatment threshold. Refine strongly the recommended, and high risk treat regardless. So you don't need to wait. And biology does not delay the therapy. You don't need, when you have a high risk, to wait for a result of ApoB or lipoprotein A. So when should we use, and now coming to calcium artery, calcium scoring. So when we use them usually as a pair guidelines. Intermediate risk by prevent score when it is from 5 to 20%, strong indications. But when it is less than 5, you don't start with it. Borderline risk from 3 to 5 with uncertainty. So decision refinement. Sometimes you need to do it if you are not certain about it. And then discordant risk marker like LDL cholesterol versus ApoB and lipoprotein mismatch results. So those time when I usually request coronary artery calcium scoring. Patient hesitance about statin therapy, support shared decision making, is still in the guidelines. And as said, calcium scoring is used when decision is uncertain, not when it is obvious. So you don't need to do it when it's obvious. And how to interpret the calcium artery scoring in the clinical practice. Usually, calcium artery scoring 0, consider deferring statin. You don't need statin, except if you think about diabetes, smoking, strong family history. So those patients, sometimes they have soft plaque. So that means they don't have a plaque which have calcium on it. And those which we see it a lot in premature heart disease, where they have soft calcium, soft plaque, and then it tend to rupture. So you need to think about it when calcium scoring is 0, but patient has diabetes, smoking, strong family history. For me, if the patient still having chest pain, so I'll go for coronary angio to confirm the etiology. Strong family history, high lipoprotein A. So when calcium scoring from 1 to 99, so this is here where you favor statin per guidelines, especially in age above 55, but calcium scoring above 100 or less than 75 percentile, so strong indication for statin. So what it's add clinically, it's reclassify patient upward or downward, identify through low risk calcium, so you are avoid over treatments and prevent under treatments of the patient, and also it support shared decision makings. So how in this guideline treatment strategy has been addressed in the 2026 approach of guidelines. So we go through step number 1, as I said, estimate risk. So using prevent risk calculator as the updated risk calculator. However, it's not been validated in our population, but this is the latest which I want you to know about it, and this is which it is just published and released online like 10 days ago. So prevent calculator, you need to do it first for patient with primary prevention. Then number 2, you go for personalized risk. You cannot use the number by itself. You need to ask for ApoB, lipoprotein A, and risk enhancers like calcium scoring, but according to the scenario of your patient. Then you reclassify if needed by coronary calcium scoring if you need. But if ApoB came high or lipoprotein came high, maybe you don't need to do coronary artery calcium scoring. Then you go and treat for target. So this is important for a step, but again, there is one important slide which is carried from the 2018 guidelines, still the same. LDL, when it is very high, above 190 or milligram or 4.9 millimole, you don't need to apply a prevent calculator. So treat regardless of calculated risk. Because this patient is having high LDL, consider familial hypercholesterolemia. Another scenario, when LDL is above 160, which it is 4.1, but you know that risk enhancer or lipoprotein is high, so you will treat regardless. Again, you don't need to apply those calculators. So those two scenario, which you don't need to apply a calculator for them. And at very high LDL level, we don't need a calculator. And this is very important to remember. So step number one, foundation therapy. As we said, you will apply the risk calculator, lifestyle plus risk factor control, blood pressure, diabetes, weight. Those all you need to, don't forget to do number one, which is lifestyle modification for the patient, control all the risk factors. Then statin remain first line therapy for all the patient. So after lifestyle, risk factor control, statin is the number one treatment. Intensity based on the risk, as we know, nothing changed. So moderate is 30 to 49% LDL reduction. High statin intensity, it's more than 50% LDL reduction. Statin is the foundation. Everything else is built on it. Don't forget that. Don't start with PCSK9 or inclisiran or ezetimibe without starting with statin for your patients. Then LDL treatment to treat to target. LDL target risk based. Again, for intermediate risk, LDL is than 2.6, high risk is than 1.8, and very high risk still the same target threshold. Lower is better by targeting depends on risk. Intensifications of strategy, if not at goal, then you add ezetimibe, which we know it will reduce LDL by 20%, add PCSK9, which it can reduce LDL by 60%. Then you think about inclisiran, alternative for adherence and dosing issue only, because the cardiovascular outcome data is still stronger with the PCSK9 inhibitor. That's why I choose it first usually. Escalate based on response, not by routine. So don't go and escalate by routine. Check the response, which it is usually 6 weeks after starting therapy. So, and then we will go for, here is the precious approach, which it is a new lipid management when you need to focus more about ApoB guided residual risk and lipoprotein little a, consider more aggressive LDL lowering. Usually when lipoprotein is high, I will go I will upgrade the target usually for higher risk, one stage higher risk. Coronary calcium scoring, guided initiations, and intensity. So this is the concept. Same LDL does not mean same risk. So here again, after discussions of ApoB, lipoprotein, and this is the main important things, we need to define risk-based target. So a risk target, like for example, if patient is intermediate risk, we aim a patient to go for a specific LDL target less than 100, let us say, which is 2.6. So at least that's mean with at least 30 to 49% reduction. So we intensify further in higher risk patient, targeting LDL more below 70% for at least 50% reduction. Speaking about percent of reduction in this guideline is more strong in tone rather than in 2018 guidelines. So reduction risk or calculate the absolute risk reduction is very important, and we treat both estimated risk and biological risk, not only LDL alone. So this is the target for ApoB if it is above 130 milligram or 1.3 gram high atherogenic burden, and lipoprotein little a, as I said, if it is above 125, so that means this is a very high risk or inherited high risk phenotype for these patients. For secondary preventions, before I finish the primary prevention now, for secondary, all ACVD, high intensity statin immediately, target LDL to less than 1.8, very high risk to less than 1.4 millimole. If not at goal, then as I said, the same approach, go for ezetimibe, PCSK9. Treat early, treat aggressively, treat to target. So very high risk population, we know, like diabetes, CKD, polyvascular disease, persistence, high LDL, one event or more than it. So now back to these guidelines. Again, this is something not new, non-HDL cholesterol. All of us know about it. If we don't have ApoB and we cannot request it in our clinic, so don't forget, we have very important surrogate, non-HDL cholesterol. This is easy. It's been calculated by itself in the lipid profile. So don't forget, you practical alternative when ApoB is not available. So this is back again to these guidelines, and they emphasize us to do it. And we know non-HDL, it's total cholesterol minus minus HDL cholesterol, and it's even clearly there in since 2021 and before in 2018 guidelines. But this is the consensus of clinical recommendation of managements from Middle East populations, where the guidelines show that you need to rely on not only LDL, but again, non-HDL and ApoB, and you can see here the target for each of this surrogate. So additional important update, as I said, I touch about absolute LDL reduction. It's a greater reduction, that means greater risk reduction. And it's not just percentage reduction, the absolute LDL reduction determine benefit. For as we know, for every 1 millimole reduction in the LDL, we reduce major cardiovascular event by 20 to 25%. So how this information is very important. I will give you a scenario of two patients. Patient A, let us say LDL 5, and you able to reduce his LDL to 3 millimoles. So patient A LDL has been reduced from 5 to 3. So absolute reduction is equal to 2 millimole. But patient B LDL 3 is lower than patient A, but you're able to reduce his LDL to 2 millimole. That means absolute reduction is only 1 millimole. So patient A absolute reduction is 2 millimole. Patient B absolute reduction is 1 millimole. So even if both achieve good percentage of reduction, who you think have a higher risk? So patient A gets twice the benefit. However, his starting LDL is 5, but because absolute reduction is higher, so he get twice the benefit because, as I said, the absolute reduction is larger. So that's how we need to think in the new guidelines about the absolute reductions. And when you reduce it higher, the first reduction, it's very important. You save the patient. So that's why very important to use the proper dose of statin for the patient. Then again, another additional important updates, residual risk of persist despite LDL control. This is a concept which it is being repeating in all expert and guidelines about residual risk. Residual risk when LDL being on target, but patients still develop progressive CKD or stroke or any ACVD. So we need to think about there is a residual risk. So it's very important to look for residual risk. Don't ignore it. And please look for residual risk, which is usually driven by ApoB and lipoprotein little a. Then again, evolving concept in the lipid management. Earlier combination therapy, do not delay adding ezetimibe in high-risk patients. Remember the idea of absolute risk reduction. Treatment is proactive, not reactive. Like, don't wait until problem happen. and risk is continuous, not just categorized. Escalate based on response and total risk, and modern lipid management integrate risk biology and early interventions. So now we came with take-home message. So we no longer treat LDL alone. We treat overall cardiovascular risk. So prevent its starting point. This is the new calculator. It's just starting point, not final decision. Risk categorize guide thinking, not treatments alone. Biology is matter, as we said. So think about ApoB, think about lipoprotein A, calcium, coronary scoring. If you don't have this in your clinic, you can do a lot of things like albumin creatinine ratio. You need to do non-HDL cholesterol, which is, the target is usually 0.8 on top of LDL target. LDL target are back, but it's not sufficient by itself. But the target, as we know it, treat based on risk level. Therapy is stepwise. Statin, ezetimibe, PCSK9. We no longer treat LDL alone. As I said, we treat overall cardiovascular risk. And I came to end of my presentation, and I'm happy to receive any questions.
Thank you, Dr. Nada, for sharing the latest and updated statements in the guideline regarding the lipid management. And now we will open the forum for question and answers. There is one question for you, Dr. Nada, that regarding the lipid management, if you can clarify the step number 4, what does it mean by treat to the target? So what is meant by the target?
Thank you for the questions. This is very important. Maybe if you remember from European guidelines, the target of LDL, usually target of LDL, we know, for example, let us say you need to know what the target of your patient. This is the first things I document in the patient file. So when you start with LDL 4 or 5 or 3, when you treat, what target you are looking for? Did you looking for target less than 1.8? Are you looking for target less than 1.4? Are you looking to target 2.6? This is all very clear in the guidelines. Each category of patient, what their LDL target. So don't forget LDL target. Don't treat randomly, and then just start a statin, and then you don't know where you want to reach with. If you don't know the initial LDL, it's very hard. If you don't know why you treat, if you don't know and you don't document clearly what your LDL target, because each patient is different according to what we know on the guidelines. So that's which I mean, treat to target, specify your target. So by that way, you will know which concentration of the statin you will start, you will calculate, and you will know the much reduction you need. And you need to treat to reach to the target, which you are, first of all, agree between you and your patient.
Thank you for the answer. Another question for you is how much can the diet alone reduce the LDL levels?
That's very excellent question. Thank you for this. Usually, I said for my patients, if we think about genetically disease, we know that it's only like 7% diet. It's a difference from case to case. If you think about this patient have 4.9, and you think about FH or persistence high lipoprotein A, or one lipoprotein A high, so you know it's genetically determined. So diet will not help a lot on those patients, and you know that only 7 and 10 maybe in maximum case it will help. But if patient have polygenic cause, a patient is diabetes, you know that this LDL is high because of increased production of VLDL particle. VLDL particle usually in diabetes, metabolic syndrome, insulin resistance, PCOS, we see that they have a lot of triglyceride and LDL is high, both of them. So think about VLDL particle. Those we know that they will get much benefit from diet. So usually we give them around, we can say 6 to 8 weeks trial, go on diet, try diets, give them a proper diet consult, refer them to dietitian, let them to be on a structured program with the dietitian, and then don't forget your patient, because sometimes patient will go and they will not come back. So usually that's what I told them: go for diet, 8 weeks, 3 months, it's okay to me, but come back, let us see if that's a help or not.
Okay. Another, I think, quick question that how much the fasting reduce hyperlipidemia, and can we rely on non-fasting lipid panel results?
That again, good questions. Nowadays, in the new guidelines, it's not necessarily to have fasting lipid profile, only if you have hypertriglyceridemia. If you have hypertriglyceridemia, I will agree to repeat, but again, many experts saying that if triglyceride above 2 or 2 point, so even if it is non-fasting, so it's considered high. But for hypertriglyceridemia in our population, which predominance of obesity, diabetes, insulin resistance, metabolic syndrome, usually I repeat it, and I tend to do it fasting to repeat, to just get the right diagnosis. But for another lipid parameters, you don't need them to be fasting. So don't miss the chance to do their lipid profile when they are in the clinic.
I agree. We have the same practice here. Another question, Dr. Nada, that we are talking about treat to target in terms of the LDL reduction. However, the major focus in this current guideline is about the residual risk reduction and the atherogenic particles and little lipoprotein. So, how we are targeting the inherent or genetically determined risk by the conventional treatment if someone is having, and you presented 3 case scenario with the same LDL level, however, differing level of ApoB and little proteins. So, how to address then in terms of treatment target?
Okay. So first of all, to say that this patient have residual risk, you need to reach to target of LDL. You cannot say this patient have residual risk if you are not reach to the target. I will give you example. If patient is diabetes, with no any risk factors. He's only diabetes, and he is, let us say, like 5 years diabetes. So no risk factor, no single risk factors. So at that time, what your LDL target? So you maybe will target to 1.8. Some experts say target to 2. So this is acceptable target for these patients. So if this patient came back to the clinic and his LDL is 2.5 and nothing has been done for him, and then patient develop CKD, let us say, or a stroke. So did that mean you are not addressing residual risk? No, you need to think about put the patient to their LDL target first, then treat for or treat for residual risk. Now, what the new in the guidelines? New in the guidelines, they need us to look for all these genetical determinants like lipoprotein A, ApoB, all this, and I agree with them. So then you can maybe be more, you target them much higher. Like, for example, for the same of my patient, who I target their LDL2, at this time when their lipoprotein little a is high, maybe I will target them to less than 1.8. And I will tell them, listen, you have one adding risk factors. So I will target you much aggressively and more higher. This is the concept of treat to target. Same concept of hypertriglyceridemia. We have a lot of confusing in hypertriglyceridemia area because usually step one treatment, because we know hypertriglyceridemia of one of the residual risk, which we need also to look for it and we need to treat it. But you need to treat it after you put the patient on their LDL target. So if triglyceride, let us say patient came to clinic with triglyceride 2.8 and you repeat it again and it is still high. So we know this is residual risk, but can we call it residual risk if their LDL not on target? In all guidelines, they said you need to first of all treat this patient to their LDL target, primary or secondary prevention. For example, if patient came with a stroke, so his LDL target is less than 1.4. If he came to my clinic with LDL 1.8 and triglyceride is high, did I need to jump and treat the hypertriglyceridemia because I'm addressing the residual risk? For sure, that is treatment. So you need to treat LDL to their target first, because when you intensify the statin, by default, triglyceride will improve. So, and here you are targeting those small particles. So triglyceride above 5, I will concern about pancreatitis. But less than 5, I will concern about cardiovascular disease. Because we know hypertriglyceridemia we can cause to the oxidize of the LDL, smaller, denser LDL, and that's which cause cardiovascular disease. So that's why I need to treat by statin. Then if it's not to target, start ezetimibe, then start whatever management you want to do to reach the LDL target. If you get LDL to less than 1.4 in this patient, then triglyceride is still high, I will treat by another modality. Then here LDL, that's where you address the residual risk. There where you start, for example, ecosapents, because this is the second line when you want to think about starting these patients with high risk and you want omega-3. I hope that I answer your questions.
Yeah, I think it's a stepwise and priority-based treatment. Another question came for you, Dr. Nada. It seems people have a lot of queries about that. If a patient is high risk of ASCVD and is a candidate for high-intensity statin, however, because of raised liver enzyme due to steatohepatitis, what is your approach?
Okay, this is excellent questions. So we have a lot of patients like this. So again, raise LFT, you don't need to worry until it is more than 3 times of upper limit of normal. We know that we have a lot of fatty livers, steatohepatitis. So LFT will be increased. You need to keep monitoring your patients. So usually if I saw it's mild to increase, I will keep the same dose of statin unless I saw it's going really very high, above 3 times of normal. So then I will reduce the dose and I will use the lowest dose can be, and add to it another modality like ezetimibe or injectable agents. And there is a lot of statin agents which can have less liver enzyme effect, but I don't know if it is available. Usually we need to request it by case to case, and then they will bring it to your patient. But you need to, first of all, to try with what you have agents in your hospital.
Yes, agree. This is what we do, that less lipophilic and low intensity statin for these kind of patient. Thank you so much, Dr. Nada. I have one question combined for Dr. Ishma. Maybe if she can have a quick answer regarding that patient who were recruited in leader and sustained trial, was the heart failure criteria or the hospitalization with heart failure was included in those patients or no? This is for Dr. Ishma.
Can you repeat the question again, Dr. Fauzia? Yeah.
There are two questions, same similar question from attendees, that in leader and sustain trial, was heart failure was included as a MACE reduction criteria or no?
Okay. Um, See, what I know that in leader and sustain trial, heart failure was not included as a major criteria, right? Usually, see, heart failure is usually included more, as far as I know, for SGLT2 inhibitors, right? So both leader and sustain were done in GLP-1 receptor agonists. So heart failure was not included as a major criteria. It was 3-point MACE, which included stroke, non-fatal MI, and cardiovascular deaths.
Yes, the 3-point MACE is a non-fatal MI, non-fatal stroke, and cardiovascular mortality.
Cardiovascular mortality.
And later on, the post hoc analysis and extended data was done for heart failure, and it only showed that numerical benefit in leaders,
Yeah.
but no significant change in heart failure in both trials.
Exactly. So basically, the heart failure part we reserve for the SGLT2
Yes,
inhibitors, isn't it? And so there
yes.
is sclerotic cardiovascular benefits for the GLP-1.
Yeah, I hope it answered the question for the attendees. Another question is for Dr. Faryal. This is the last question, and then we will move to our next lecture. This is can Dr. Faryal elaborate if someone on a statin therapy develop diabetes, and if develop, how to manage it?
Hello, good evening, everyone. Regarding the question for statin-induced diabetes, the risk is really, really very low. It's 0.2% per year, the risk. And in one of the systematic review, if the more than 200 patients are treated with statins for more than 4 years, then there is a risk of developing one patient of developing diabetes. So this is the area where there's benefit versus risk ratio. So if we are targeting the 3-point MACE and the risk in cardiovascular mortality and risk of developing diabetes is really low, then the patient needs to be just aware of it, and patient needs to have a baseline regular follow-up with the blood glucose and HbA1c. Regarding the treatment part of statin-induced diabetes, I am not aware of that particular area. I can answer this after going through it to the attendee later. I'm not aware of Fozia, if you can help in that. How do we treat statin-induced diabetes?
The statin-related diabetes incidence is low, as you mentioned, that at absolute risk is less than 5%, and relative risk is up to 9 to 15%. And because of the increased insulin resistance and some effect on beta cell reserve, the diabetes happens. So management is exactly the same, because the underlying, usually the risk factor is metabolic syndrome and pre-diabetes. It's by the lifestyle changes followed by the usual therapy based on the risk stratification. There is nothing new and nothing unique to the diabetes secondary to the statin induced, because most of these patients have underlying same metabolic risk factors like a normal person. It's only that incidence got a little higher than the normal person without statins. So management remains the same in the same guideline, and same risk stratification has to taken into consideration for that.
Okay, great.
Maybe I can add in this if you don't mind.
Sure.
Think about
Sure.
pitavastatin. Usually, pitavastatin, because it's minimal CYP metabolism, so mainly it is glycorenodation, so it's different way. So there is a fewer drug interaction. It's lower in causing diabetes induce. In patient with who are you think they are at high risk pre-diabetes, or A1C is high, or the patient is too much concern, maybe you can start with pitavastatin.
Pravastatin, yeah.
It's
We
coming
usually prefer
from
pravastatin and all
yeah,
that. They are less
pita.
lipophilic.
Yeah.
Yeah, they're less lipophilic. So pravastatin is better for those who are concerned and shows the higher risk of developing diabetes. So here I would like to thank all of the speakers and great audience for having a very interactive session. And sorry for a little bit extension from the time. Now I would like to introduce Dr. Jalal Nafash, who is today our last speaker. Thank you for your patience, Dr. Jalal. And we are going to have a new real-world evidence about ED2-DIA study. Dr. Jalal is consultant physician endocrinologist in Dubai Diabetic Center, and maybe he can share the screen.
Can you see the screen now?
Yeah, we can see that.
All right. So this is me. This is my picture, maybe like 3-4 years younger with some Adobe Touch anyway. So I'm going to go quickly over an old drug. I'm not discussing any new data really. This is just a presentation unrelated to DAC. So when you go to diabetes, as a fact, it's becoming much more prevalent. So now at this time is almost 1 in 9 have diabetes. And if you go back to, for example, 2003 or so, at that time, the number of adults with diabetes was about 222. And at that time, the estimation was to be in the mid 2020, so mainly now, to be about 333 million, but we already bypassed that. We expect to be about 850 million in 2050. Most likely we'll bypass this number too. Now, of course, we know that it's associated with the increased micro and macrovascular diseases. The problem is, despite of everything we have, the vast majority or big number of patients are uncontrolled. Typically, most of the data will show you at least 50-60% have an A1C above 7%. Now, again, assuming 7% is your target, typically you need to have a tighter target in a younger population, maybe trying to go to an A1C below 6.5. And if you look at the newly diagnosed diabetes, it seems to be beneficial to have even a tighter control because that you will guarantee you to have a more lasting effect. Now, the problem is what happened is most patients are uncontrolled, and typically, and we know that from European and American data, that the initiation of any other drug typically is oral. So if somebody failed first to go to 2-agent or 2 to go to 3, usually it takes about 2 to 3 years. And the initiation of insulin could take about 6 to 7 years, despite the fact that the A1C running over 8%. So that's really a major problem, and it's related part of it physician, part of it, of course, patient-wise. And that despite the fact that we know that especially when you treat people when they're newly diagnosed as UKPDS, you have reduction in microvascular disease. And not only that, if you look at the UKPDS and you look at the 10-year follow-up, you have a reduction in all-cause mortality, you have a reduction in cardiovascular disease, and even we have the recent data on 44-year follow-up. Now, of course, 44-year follow-up on the UKPDS, big number of patients are deceased, but still you continue to see that there is some kind of what call metabolic memory. So those who you control very well, very early in diabetes, seems to continue to have lasting effect even on the mortality. So if anything you need to remember from this talk is when you have a patient, newly diagnosed patient, be aggressive, get them down, get them fast, and get them very tightly controlled. Don't aim for 6.9, even if you can get them lower, it's maybe better. And it seems clear that if I keep the A1C very well controlled, I'm more likely to maintain the control. Now, we have this guideline, we've seen it many, many times. And again, when you look at treating patients with diabetes, you have two portions. You have to look at agent to reduce the risk in patients who are high risk or established disease. Now, again, big number of our population are high risk or very high risk. So you have to use medication that reduce the risk as SGLT2 and GLP-1. Now, of course, if you have more of atherosclerotic disease, you're going to use GLP-1 irrespective of the A1C. So if you have a patient with an A1C of 6.2 and taking DPP-4, but they have history of MI, then you need to change them to GLP-1 that has a proven benefit in reduction in the risk anyway, even though the A1C is 6.2. Now, if there's more of a heart failure or kidney disease, your first preference, of course, SGLT2, saying that we already have data on reduction in the heart failure in using semaglutide, and also the same on the kidney disease from the FLOW trial. When you look at the glucose lowering arm, again, we have to look at the patient, how much reduction I need to have. And if I need very high, very potent drug, the most two potent drug really is semaglutide and tirzepatide, and maybe dulaglutide high dose. And then the high potency is again GLP-1, TZD, SGLT2, and sulfonylurea, and less effective is DPP-4. So it depends how bad your A1C. You're not going to have an A1C of 9% and just add DPP-4 because it's not going to get you to target. So for example, if you use DPP-4 with an A1C of 8.3, you're ought to get an A1C below 7 is somewhere about 35%. Of course, the more effective the drug, the more likely to get you to target. Now, when we come to talk about gliclazide, and again, it's a very old drug, what we know is we have a lot of data on it. The most significant, really, what you call the advanced trial. Now, the advanced trial was a trial done on patients who had, duration of diabetes somewhere about 8-10 years. But the point is, it was not really a CVOT trial, but it was designed somewhat similar. And what they seen in this trial, that the patient who did receive gliclazide, they were able to maintain very good A1C throughout the trial. And if you compare how much drop in A1C versus the baseline A1C at the beginning of the trial, those who had the A1C of over 10%, they had about 4.3% drop. So it's a very effective drug. And not only that, we already have in vitro data that shows that when you incubate beta cells with the product, actually don't see as much of beta cell loss where you see it in other sulfonylurea. So we used to always have concern about SU that it may cause what we call quote unquote beta cell exhaustion, which it doesn't seem to be the case at all with the gliclazide. So this is on the right side is a retrospective analysis on the data and trying to look at the time they started glyphosate versus glucosamide, and you can see that the time they needed to start insulin is quite significant between both arms. At the end, whatever agent you're going to get, it is progressive disease, and at some point you're more likely to start on insulin. Now, what's about the safety? At any drug, you need efficacy, and I showed you some data on the advanced trial, and I showed you the durability of the effect of the drug. When it comes to the safety, I think the most prominent is see what happened when we fast. And this is the Ramadan trial published, where they look about 1,100 patients, and they were looking at patients who were taking glyphosate and see what happened during the month of Ramadan. And you can see that there is very low risk, actually 4% of symptomatic hypoglycemia, 0.6% of confirmed no severe hypoglycemia, and actually no weight gain, actually weight loss. But I think the most important is the second trial I'll show you, which this is in this trial, patients were taking sulfonylurea, including glyphosate, glimepiride, and glibenclamide, and they were randomized 1-to-1 to either keep the SU they were using or go to sitagliptin and look at the incidence of hypoglycemia during Ramadan. Now, what you can see here, that actually the incidence of hypoglycemia is similar between glyphosate and sitagliptin. So again, it shows you the other data in the Ramadan. So it stands to the fact that it does not carry the same risk of hypoglycemia we used to always concern about with other SUs. If you compare to glimepiride, it's double the risk, and glibenclamide is 3 times the risk. So there is a difference between the three. Actually, I have not used glibenclamide for years and years. Now, what's about weight? Now, again, those are not head-to-head trials. Here, just showing you data from the different trials. So the advanced trial I alluded for before, which was about 11,400 patients, and they did not have any weight gain. UKPDS, there was weight gain. Accord, there was weight gain. And again, they use a different sulfonylurea, and it seems that there is more weight with it. Now, again, it's a different population. They have a different background medication. In VIDT and Accord, there was also insulin use and TZDs. But what I'm trying to say is it does not seem to carry this weight effect. And I showed you also the data on Ramadan. So you have strong evidence of efficacy, as you see in advance. You have low risk in the hypo, as you see in the Ramadan and the other Ramadan trial I showed you, which patient were randomized versus sitagliptin, and you don't have as much weight gain. Now, the other part is, do I have any benefit? And again, I mentioned earlier the advanced trial. And of course, at the end of the trial, what happened? The investigator stopped the trial, and they did a follow-up trial 10 years down the road called Advance On. So mainly, they went back and see what happened to those patients who, the majority of them may not be taking glyphosate. It's somewhat similar to what you see in the VADT trial, follow-up trial, or the UKPDS follow-up trial I showed you. And when you see here that there was actually continue to have reduction in new onset microalbuminuria, new or worsening nephropathy, new onset of macroalbuminuria 30%, and a reduction in progression of end-stage renal disease 65%. And this is 10 years after stopping the trial. Again, in the initial trial, the difference of A1C was about 0.8%. So what I'm trying to say here, there's some kind of benefit. There's some kind, if you want to call it metabolic memory, but those patients who were treated very well early maintain the benefit. And that, again, resonate with what we've seen in the data from the UKPDS. So at anything you need to remember, get their glucose down and keep it down. And not only you're going to reduce microvascular disease, you may have even macrovascular benefit. Now we go back to the guidelines. And again, in the guidelines, I think most of the talk and the lecture we talk about is talking about cardiovascular reduction. And there's nothing wrong about that. But I think sometimes we have to remember that, yes, you should use agent to reduce event, but that should not stop you from controlling the glucose. So for example, if you have a patient who has GFR of 40 and you're a microalbumin and you decided to add a GLT to control them, well, in those patients with such a low GFR, the A1C reduction with SGLT2 is not enough. And typically you need an additional agent to lower the glucose. So you should not always say, well, I'm going to use an agent that reduces cardiovascular disease and renal disease, and I forget the glucose. What you need is you need both. And if you start with medication that reduce the event in those patients with very high risk, and you continue not to have a target, you need to consider, of course, as adding an agent that lower the glucose. But also you can look at the idea that maybe I'll use a combination that I'm using medication that lower the risk, i.e. SGLT2, GLP-1, plus medication that is effective and in a way safe, as I showed you the data on hypoglycemia, no weight gain, and again, continuous benefits, as I showed you in the ADVANCE-1 trial. And so the idea is to look at this trial and say, what happened on patient who's taken, gliclazide MR, and I'm going to add SGLT2. Am I going to have a good efficacy or not? And so the idea is I'm using gliclazide, which improves insulin secretion. It has low risk of hypoglycemia, the later generation sulfonylurea, and look at those patients when I add SGLT2. And of course, I'm doing it for glucose reduction, cardiovascular benefit, and on top of the other benefit of SGLT2 as delaying the progression to renal failure, and in addition to the benefit on the weight loss and blood pressure reduction. So in this trial called Add2DIA, what it was 5 countries, 25 physicians, 500 patients. It was retrospective analysis looking at this population that did receive SGLT2. Now, of course, they had a baseline data they collect and follow-up data. What they needed is they needed to make sure that patient had at least 2 years of type 2 diabetes. Now, the average duration of diabetes in this population was 10 years. They were treated with gliclazide, at least 60 milligram, at least 60 days. And they needed to have information, including the A1C, at least one at 60 days. They have a longer duration follow-up, but they don't have data on all the population for all the time. And then they were allowed to look at this population who were taking a baseline of metformin, DPP-4, and insulin dose, low dose below 20 units. And in this population, again, about 70% of the patients were below 65, about 60% of them have dyslipidemia, 2/3 of them with hypertension. And what you see here, that 75% of them had a BMI 25 or above. Established cardiovascular disease was only in 15% of those patients, and about 2/3 of the patients were treated for the high blood pressure and hyperlipidemia. Now, what happened when you add SGLT2? Well, the first thing you need to remember, this population exactly reinforced the fact that we're not doing a very good job. So in this population who had the average duration of diabetes of 10 years, the average A1C was 8.7. You have 1/3 of the patient with A1C of 9% above, about 1/4 of them 8 to 9%. And they were taking already gliclazide with average dose of 76, but they did not advance the treatment. So again, it go back to the time that those population, despite the fact that they're uncontrolled using gliclazide, they did not add another agent, in this case, in this data, SGLT2, for 3 years. And again, this is the same problem we have, that we procrastinate, either us or the patient, to try to introduce. And actually, this duration should not be 3 years, should be only 3 months, and then we add another agent. So what happened in this population? When you look at the A1C reduction in the whole cohort of the population, that they started with the baseline A1C of 8.7, they dropped to about 7.8. If you look subgroup analysis on those who started with the A1C of 7.5 or above, the drop was 1.2%. And in this population who has a 9%, the drop was 2.2%. So again, in this population, the higher the A1C, the more drop. And we know that with SGLT2. And so, again, it seems that the combination is working well. Now, if this is the data on 6 months, when you try to look at the end of the data, which is about 2.4 years, you can see that patients continue to have NAS reduction. So those who start with the baseline of 7.5 have a reduction of 1%. And those who has a baseline above or equal 9%, and this data is 10.4, they drop to 8.5. Now again, is 8.5 controlled? No, but it's much better. And again, this is by only adding the SGLT2, and that's the typical reduction in A1C you see with SGLT2. Now, what happened with the weight? Again, as the other trials I showed you, including the advanced trial, there was not really a weight gain. And in this case was weight loss. Now, does it mean gliclazide make you lose weight? No, but it is weight neutral. It does not cause weight gain as the older generation sulfonylurea. What's about the lipid? Now, typically, as you use a GLT2 or any other agent, when you drop the glucose, it's typically you're going to expect reduction in the triglyceride. Now, there was also reduction. The LDL could be also part of it. There was change in the medication during those 2.4 years. And there was the typical drop in the blood pressure, which was about 2 millimeter. What's about the discontinuation? Was there a lot of side effect? So actually, when you look at it, you can see that the majority of patients were taking this medication for a long time, at least over 3 years, and the discontinuation rate actually in the combination was less than the discontinuation rate in SGLT2 and gliclazide MR. Does it mean that when you take them together, you have less risk of discontinuation? No. But what we're trying to show here that it did not really increase the discontinuation rate. At least it did not have any more adverse side effect. And that again shows that not only it's an effective combination, it's actually has a low chance of mainly side effect of the patient. So I think I talked a little bit too fast. I was trying to catch up. So it's already about 10 p.m. But we need to remember that type 2 diabetes is a progressive disease. ILDA is multi-pathophysiological abnormality. You have to try to address as much component as you have. You want to be aggressive from the beginning. If you can get the patient 6'2" and keep them 6'2", that's the best way. Don't just look at the 7 as a magical number. Glucose control is very important. It is very important to use medication that reduce the risk, but that does not take off the fact that we need to get the glucose down, and that's still a priority, as equal, if you want to call it, as the cardiovascular. Gliclazide MR is an effective. I showed you the data that when you have an A1C above 10 in advance, the drop in the A1C was 4.3. And again, the patients in advance, had a very nice A1C at the end of the trial in the mid-6. So that again stands to the safety. The risk of hypo, I showed you, clearly from the 2 studies in Ramadan that it was not as much. Weight gain is not as much. And I showed you this data, the AD2DIA, and I showed you the data on the advanced trial. And then when we go to the AD2DIA, as you've seen, there was a nice reduction in the A1C. So the combination seems to work. In this population who has a baseline A1C about 10.2, which is the collection of patients who had above 9, have a very nice reduction that maintained at 2.4 year. There was a low risk of hypoglycemia. There was a nice drop in the weight and drop in the blood pressure. And I think I'll stop at this point.
Thank you so much, Dr. Jalal. And I understand it was fast but very clear and comprehensive. So we got the message, and there is no doubt that eventually the diabetes requires multiple medication, and most of the patient end up taking different medication. So there are few questions as well as asking to you that do you think that gliclazide can be used in combination with SGLT2 would result in weight loss?
No. I mean, the weight loss is not from the gliclazide. I was very clear. It's a weight neutral. The SGLT2 weight loss is typically average 3 kilogram plus minus. And what you see with the SGLT2 is they maintain, there is a data, for example, on dapagliflozin for 4 years, where you had the weight loss and then you maintain it. So with the SGLT2, typically you tend to have a weight loss that happened early, and then you maintain the same weight loss. You don't continue to lose. So, when you start patient, for example, on SGLT2, and you tell him you're going to lose some weight, and they say, how much? And you say, about 3 kilo. And they say, in what? In a month? I said, no, that's it. It's the expectation of the people. Yeah. So, no, but it's not the gliclazide.
Yeah.
But it does not cause the weight gain as the older issue.
Balance is a bit of a fact.
Yeah.
And the question is that can we use gliclazide safely in elderly patients?
If you have a patient, again, it's all about the balance. So if you have a patient who has very high risk of hypo, if you have a patient with renal insufficiency, you have to be extra careful. You're not going to use gliclazide your first agent. But if the glucose is very high and you need to lower it, then that, of course, that's a choice.
Exactly. And there is another question, when should insulin be preferred early in the treatment instead of oral medications in type 2 diabetes?
Okay, so I rarely, well, how to say it this way? I mean, I in the old days, insulin was, I mean, you used to have metformin, old SU, and insulin. But now I think change, I really try to show insulin. I have as high A1C of 17% on presentation, and I did not use insulin. Now, again, don't do it. It's a little bit high risk, but I did it. So what I'm trying to say that the time you use insulin early in the diagnosis of diabetes is if you have a suspicion that the patient may be type 1. So you start from an insulin, meanwhile, you check their antibodies and so on, choice one. Or in patient who they have progression that they're not responding to oral slash GLP-1. GLP-1, GIP is the preferred first injectable therapy. So if I have to look at injectable therapy, it's better to start with GLP-1 or GLP-1 GIP before insulin. So really the insulin will be the last one. The second thing, it'll be important to look at patient glucose reading. So if you have a patient, if they're taking oral agent or even GLP-1, and they're having uncontrolled A1C, then I would like to have the readings to see how they look like. So I'll ask them to do some fasting and maybe like typically I tell them 3 days before you come, check fasting and 2 hours after each meal. So let's say an example, their fasting is 110, but the after meal is 210. This patient, you cannot give them basal insulin because this patient, if you give them basal insulin, they're going to get low overnight. So the idea of I start anybody with high A1C on insulin is wrong. I do have people, about 10-15% of people who use insulin, they may not need basal insulin. So you have to look at the reading. So in a patient like this who increase with meals, really, if you're going to use insulin, you may need meal insulin, or you need to adjust the diet, of course. So look at the patient, try to get more recent numbers the last 2-3 days to make a decision on an insulin, but I would not choose the insulin as the first injection, except if they're ketotic sick or I'm suspecting there may be autoimmune. I cannot hear you.
Thank you so much, Dr. Jalal, for the answer.
Yeah.
And I really appreciate all the interactive audience. And
Thank you.
last but not the least, we would like to remind that we have upcoming session tomorrow for our another initiative, uh, inshallah, in 29 April 2026. That's a virtual platform. And it is about the exchange of different challenging cases and interesting cases throughout the globe as well as the region. And that's the first ever session going to take place on 29th April. It would be the quarterly virtual sessions and followed by in June. So we would like to invite and welcome all the participants to again join us in this platform as well as for the Tomorrow Create, which is a learning initiative by EDS and Sharjah University. And this is again a virtual webinar, and tomorrow's by Dr. Harry Shirley. That's going to be from 7:30 tomorrow night till 8:30. And so far we are having a lot of research related initiatives and program through the Create. And regarding the today's session, the CME will be available almost after 4 weeks. From that onward, you have to fill your evaluation form on your registered email to get the CME credits. And you can also watch the recorded video on our EDS YouTube channel later on. And please, in evaluation form, mention that would you like to know more about the further session in the future, and you can give your whole opinion and input in this the one in the screen which is mentioned the site as well. So you can watch later on if you have missed part of the lecture today on demand session. And here I will end the session tonight. Thanks again to all the speakers, panelists, and all our audience and for the interaction. Have a good night, everyone.